الترانسميشن جروب كمان كلها كانت اكسلنت. طبعا بنشكر جينسن. انا عارف ان احنا النهارده عندنا 5 توبكس، هنحاول نبقى سرعه شويه. طبعا بيشرفني يكون التشير بتاعي النهارده دكتوره عبير ودكتوره اماني. ويلكم دكتوره عبير، دكتوره اماني.
اهلا دكتور عزت. congratulations for the 7th wave of IBD edu. ان شاء الله عقبال المره 70 ويا رب تقدم من نجاح لنجاح. وكانت امبارح كانت اضافه جديده ان حضرتك تعمل ورك شوب من الاليكس سكوب، كان اضافه جديده عشان IBD مش بس ساينتفك، ده براكتيكال كمان. فشكرا لحضرتك ويا رب ان شاء الله كل مره فكره جديده وتقدم جديد. تسمح لي اقدم حضرتك بقى المحاضره دي؟
اتفضلي.
النهارده دكتور عزت هيبدا افتتاح IBD ايديو بمحاضره عن IBD in elderly. طبعا facing the problem، هي it is a real problem، ويا رب ان شاء الله يكون المحاضره دي فيها solving the problems من الدكتور عزت ان شاء الله. اتفضل دكتور عزت.
بالفعل ال IBD in elderly is a progressive, cumulative, and the frequency, incidence, and prevalence. I think we have a lot to discuss today, starting by some definition that the age group up to 70, we call it young old or not so old. And between 70 and 90, we call it old, just old. Above 80, we call it very old. I mean, we have a triple level as regarding this age distribution. As regarding the medical study of aging process, or what's called gerontology, it's just the medical study all about aging. But when we study diseases that affect the elderly, we call it geriatrics. New definitions and new vocabulary and new word we use, and we have to respect. Our session will pass through main 5 topics: incidence, prevalence, hot topics inside this group, risks, treatment, and surgery. First, we talk rapidly about incidence and prevalence. With this review, there is big area for study and research as regarding the incidence and prevalence of IBD in elderly, starting by the eco definition of elderly onset IBD, that is a disease onset at the age of 60 or more. When making management decision in elderly, clinicians should access an individual priority rather than only considering an individual chronological or biological age. The rising incidence of IBD and the growth of our aging population are contributing to a rapidly increasing number of elderly IBD patients. About 25 to 35% of IBD population is over the age of 60, of whom about 15 have been diagnosed relatively late in life, and about 20% are IBD patients who have transitioned to older age. That is the transitional zone of IBD between the adult and elderly. I think the percentage which we met now is so high and need more and more work. The incidence rate of UC and CD peak in the 3rd and 4th decade declined thereafter, although the number of patterns can be censored in this decline. For example, for UC, among a sizable cohort in Canada, Denmark, Northern California, no decline in UC with age, while in the other population, there is marked decline and more affection of women even absent in men. It's very controversies between the two groups, with little evidence coming from our developing world as regarding the age-specific incidence. For CG, we have either no decline of CG in elderly, or in the majority of the study, there is marked decline in old age, both women and men, with the later, both men and women, with the later being the more pronounced as the decline is from higher incidence rate in young adult life. There is no report on the prevalence of IBD in elderly. Now we have different gaps from the epidemiology. We have a gaps as regarding these hot topics. It's likely that the elderly make up a slightly lower proportion of prevalence cases given their increased mortality from other causes. But we have what's called temporal trends in IBD in elderly are difficult to access. However, it's likely that the incidence will rise in the future or is currently on rise. I think we have a new paper, some to be discussed about the four zone of prevalence and incidence of IBD all over the globe. And they said that we are in the accelerating phase as regarding our zone. The second, what are the hot topics in elderly? For example, the risk factor for developing IBD in elderly. We know that the gender, the family history, and the obesity may play some role in the IBD, but in conclusion, trend in risk factor observed with age in younger age group generally continue to older age, suggesting that old age onset IBD has a similar underlying etiology to that observed in young subjects. However, many risk factors of IBD are determined nearly exclusively in young population. I mean, we need more and more data about this age group as regarding the definite etiological factors. For example, as regarding disease presentation, it's very hot topics. Commonly, we said that maybe an atypical presentation. However, the first symptoms of IBD are more or less similar to adult and elderly patients. So we have no atypical presentation as much as we find. Abdominal pain and systemic complaint, such as fever, weight loss, less frequently observed in elderly patients than in younger IBD. It's very important. When you come to CG, which more affection with a chronic affection in elderly, it means that rectal bleeding more. So elderly, common location, CG is chronic, making rectal bleeding is more pronounced. It is a big differential diagnosis for ulcerative colitis. How is it's less often report abdominal pain as the first presentation. For UC, we find two things very important. The hospitalization is more for the first flare, which is not common in young or adult IBD. And when we're looking for the CG, we find that may surgical resection at that time in contrast to adult onset IBD. So elderly, you see early hospitalization, elderly in CG, commonly we find them with surgical resection. And these observations come from either more severe presentation, a more difficult diagnostic process, or fatality of this patient population. The differential diagnosis is more diverse in this group. Very important. So good history taking, endoscopy, including taking a biopsy, are important to discriminate IBD from others. What are the others? Number one, infectious gastroenteritis. طبعا يجي هنا second common هيبقى more diseases in adult like ischemic disease, diverticular disease, microscopic colitis, NSAIDs induced enteritis, radiation colitis, and rectal ulcer syndrome. I think we have now a new era to signify and stratify the main differential diagnosis. So it makes the echo practice position. Elderly patients with CD tend to have more rectal bleeding and less abdominal pain, fever, or weight loss at presentation. In UC, the clinical presentation is similar among age group. Coming to the next echo position, statement 3, diagnostic workup in elderly doesn't differ from adults. However, the differential diagnosis is more diverse in elderly, and in particular, as we said, malignancy, infectious, ischemia, microscopic colitis, segmental colitis with diverticulosis, non-steroidal induced are very important to be excluded. Coming to the course location, we find there is big difference according to extent and the location of the disease. For example, ileoclonic involvement, that is L3 in CG, and extensive disease UC are less common in elderly. In elderly CG, chronic involvement L2 is more common than ileal L1. However, in UC, left-sided colitis is the most common. In spite, the young, we common say that proctitis is the common, strict rectal disease is less common in elderly than adult type. Regarding the phenotype, the current literature is divided on the number of elderly with P2, that is a stricturing type, or P3 penetrating type CD phenotype, ranging from less to more complicated phenotype and diagnosis. And in spite of that, the progression, either P2 or B3 during the course of the disease is likely to occur to lesser extent and to the same extent of adult type. As regarding hospitalization in CG, we find that the IBD-related hospitalization in CG were found to be similar for both adult and elderly. In elderly IBD, we found that more longer post-operative stay and the higher hospital mortality rate. So the rate is equal. However, the post-operative stay and mortality higher in elderly. In UC, higher risk of being hospitalized. As we said, we commonly, the UC in elderly hospitalized early, in particular for the first flare. No difference in risk surgery were found either at diagnosis or long term, and data on actual course of the disease are currently leaking. This information is especially relevant to elderly population, as the treatment may be more focused on symptom control rather than optimizing the outcome. So, making the current clinical practice position of the ECO4, saying there is in elderly, CG more often have a chronic involvement rather than ileal involvement. In UC, disease extent at diagnosis is most often left side, while extensive disease and isolated proctitis less frequent than adults. Also, the risk of the IBD-related hospitalization is higher in elderly UC, but not in CG than in young adult. Elderly CG have higher risk of surgery or what's called shortly after diagnosis, whereas the long-term surgery rate similar between the adult. For UC, no difference as regarding the risk of surgery. The next is what's called the risk we met. Number one, infection, complication, and vaccination. Infection in overall, the serious infection are more common in elderly patients, especially those receiving oral corticosteroids. We have to signify Clostridium difficile infection in older age as a well-known risk factor. UTI and sepsis more common in elderly. TB increases with age and the use of anti-TNF. So every patient checked for TB prior to initiation of immunosuppression or even biologics. Coming to opportunistic infection, we consider that the age above 50 and immune modulator are risk factors. Looking, glucocorticoids and the candidiasis are linked. Other opportunistic infections are common. Elderly more than 65 years treated with anti-TNF بنلاقي فيهم more and more severe infection and mortality rate. Considering thioprine as a greater risk for viral infection, cytomegalo, herpes simplex, and varicella zoster virus. However, advanced age is an additional independent risk factor that is making more and more vaccination to be needed. It's very important. There is an increased risk of varicella zoster virus infection in elderly, so should be vaccinated before any immune suppression treatment. Pneumococcal and influenza vaccine, it's two common causes inducing morbidity and mortality above the age of 65 and can be prevented by vaccination. So pneumococcal injectable influenza vaccine should be administered every year, whatever the disturbance between the relation of immune suppression. And coming to the pneumococcal vaccine, it should be given and reactivation after 5 years. This fragile group need more and more vaccination and follow-up. Infection and the related serious complication as regarding the eco-current practice position are more common in elderly, emphasizes need to more follow immunization guidelines thoroughly. As regarding neoplasia, CRC in a long-standing IBD is very important, whatever the discrepancy, but we find that recommendation for ongoing surveillance in elderly population should be taken in consideration the impact of comorbid illness and the increased age on the anticipated risk and benefit of colonoscopy. It's very important. There is difference as regarding, however, there is no clear increased risk with advancing age. We consider that the long-standing IBD, as we said yesterday, and increased risk of small bowel adenocarcinoma related to each other, but the data are sparse. That's making that the benefit of surveillance colonoscopy, yes or no. The lymphoma is very important. We know that is according risk increase with the age, according to what's called SEER, that is surveillance epidemiology in the results database, azathioprine and 6-mercapturine showing 4-fold increase. there is big difference or big controversy between the biologic. However, the anti-TNF may play a role, especially in non-Hodgkin lymphoma. And should be noted that the patient over 65 years receive immune suppression or immune modulator have an increased risk of non-melanoma skin cancer. That is making elderly patient with a long-standing disease require screening for colorectal cancer. Early onset IBD is not associated with an additional risk of CRC, although the time between the onset of the IBD and CRC diagnosis is shorter in elderly. Therefore, one should consider enrolling elderly onset IBD in CRC screening program sooner after IBD diagnosis. However, CRC screening in elderly should be balanced with the disease severity, comorbidity, and life expectancy. Coming to the treatment, we should know that medical treatment, we have a lot, but there is lot of studies and lot of data about the nature of drug we use and side effect and drug-drug interaction and special precaution and special recommendation. We should know they are elderly, multi or poly, what's called polypharmacy, and we have some precautions as regarding this medication. And when looking for the biology, we find that the updated or the late biologics in the market, like Vido, Ustekinumab, Tofacitinib, they say that's to somewhat considerably safe in this age group. But however, we have some consideration that the topical therapy in elderly may represent special challenges relating to the sphincter incompetence and coordination. The physical reverse may not tolerate a flare-up of the colitis as well without intensive medical treatment compared to young. Polypharmacy and complex regimens is very important. Possible intellectual impairment and lower life expectancy. Choose better quality of life, that is the hope of adults. Never forget the cognitive deficit and depression, which was common in elderly. The efficacy, there is no difference in response as regarding corticosteroids, amino salicylate, no difference in efficacy even with the use of thiopurine, and also no difference with anti-TNF therapy, with some controversies as regarding the early results and the late results, and some studies say there is a slow response to anti-TNF depending on the pharmacokinetic and the mechanism which the disease comes from. The combo study shows that suggested higher efficacy of combination therapy of anti-TNF and immune modulator compared to monotherapy, especially regarding steroid-free. No such study has been performed in elderly. So we take the data from other diseases like rheumatoid, which help us in this. There is no evidence of efficacy of medical treatment. Elderly IBD patients differ from that younger adults. It's very important. As regarding safety, never forget amino salicylate use and nephrotoxicity. Never forget thiopurines and its interaction and the production of lymphoproliferative disease. And never forget the age itself as a playing factor independently for this side effect. And even so, making sometimes the anti-TNF in comparison in different studies, making Mayo Clinic suggest a significantly increased risk of infection in elderly patients with about twofold risk in the discontinuation of therapy as a result of infection. And also, never forget methotrexate, non-steroidal, and its affection and renal toxicity. It's very important. Methotrexate and the myelotoxicity. Lastly, cyclosporin is best to be avoided. So all available data indicate a higher risk of adverse events with prolonged use of steroid elderly patient when compared to younger adults. The use of thiopurine in elderly needs careful consideration monitoring due to potential drug interaction, increased risk of lymphoma, non-melanoma skin cancer, and the infection. Elderly treated with anti-TNF have an increased rate of severe infection compared to young drug-drug interaction. We know the polypharmacy and the accelerated steroid clearance, especially in patients using anti-epileptics, the potential burden of polypharmacy, some interaction as regarding the anticoagulant effect with 5-amino salicylic acid, azathioprine, and aspirin, and clopidogrel. all of them are very important, as we will said, and the relation between xanthine oxidase mediated action of allopurinol, which may be used in our patient to potentiate the effect of thiopurine. So polypharmacy from existing comorbidity may be common in elderly patients, and the potential of drug interaction must be considered. Problem of administration should be carefully considered. We shifted to very hot topics that thromboembolic manifestation. Antithrombotic prophylaxis should be considered in all hospitalized elderly patients with IBD. And even treatment of venous thrombosis and IBD should be follow established antithrombotic options, taking into account the potential risk of bleeding. That is the non-pharmacological prophylaxis in IBD to decrease the thrombosis, the hydration, correction of some vitamin, B12, folate, P6 may important. As we said, aspirin, clopidogrel, not inducing a flare, and sometimes not inducing more hospitalization. However, the risk of the bleeding during using this medication in IBD, especially in cardiovascular disease, should be assessed and should be taken in consideration. So in general, IBD patients at high risk of thrombotic complication, which represent an important cause of morbidity and mortality. No evidence intensify of that intensity or frequency of IBD flare increased by antiplatelet. So it is prudent to offer aspirin to patients with associated cardiovascular morbidity where compelling evidence existing to support this. The withdrawal, no withdrawal trial in elderly as regarding the immunosuppression agent anti-TNF have been performed, especially in elderly. Never forget that is another window for the research in our globe of the IBD. Shifting rapidly to surgery, necessity for surgery in IBD, elderly patient, 4 studies show reported rate of total colectomy and segmental colectomy. In elderly UC, less likely to undergo surgery compared to younger age group. Late onset UC experienced no significant difference requiring colectomy. In severe UC, early surgery has been recommended for elderly to reduce the complication. When comparing this with younger adults, we find there is a big difference. As regarding IBD, the necessity for surgery appears to be lower with a higher age at the onset of the disease. If surgery for CG complication is necessary, technical approach is not difficult from that used in young adults. Complications, several risk factors for post-operative morbidity and mortality increase with the age. So increasing the age is an important independent risk factor for post-operative morbidity and mortality. Also, never forget the other complications like anastomotic leak and pouch-reduced septic complication and pouch failure. The rate didn't differ from the young adult and the elderly. So it's very important to mean that is elderly will suffer as the young IBD from the same complication. That is making the indication of surgery are not different between elderly and the young adults, and even both between UC and CD. And the age alone is not an accurate predictor for their surgical risk in IBD. In UC surgical approach, patient requiring pouch surgery is not different from young. However, due to possibility of decreased anal sphincter function, the option of pouch versus ileostomy should be discussed. Never before we end our talk that we have what's called the unique challenges in elderly IBD. That is the stigmata which have a very, very important during our multidisciplinary assessment and treatment for this patient. They suffer from different challenges, and as a doctors in our field, we may need help from a geriatric physician to help us in this. Cognitive deficits, dementia and psychiatric disorder, frailty and impaired nutrition status, caregiver burden, polypharmacy, increased comorbidity, and increased malignancy. I think these 7 factors are very important when to try to prescribe any medication in elderly IBD. And at the end, take home messages that the elderly IBD, especially in incidence behavior, elderly IBD show distinct location and disease phenotype and course. elderly IBD has a special concern about IBD medication and polypharmacy. Elderly IBD and surgery and post-operative complication have a special trend. Unique challenges in IBD patient in elderly IBD patient should be respected. Thank you.
Thank you very much, Professor Izzat, for this very nice and demonstrative lecture. And I think I saw a message from Dr. Allen. So would you like to postpone the discussion after the next lecture?
Yes, it's better to go like this.
Okay. So now I think we are going to move to the next session. Thank you again very much, Professor Izzat. Thank you, Professor Habir.
Welcome, Allen. Hi. Please unmute.
Fantastic conference.
Hi, how are you, my friends?
I'm doing very well. This was an impressive talk. It was a very thorough review of the guidelines and the consideration in the elderly in IBD. So I'm glad I caught this talk, and I want to thank you and congratulate you on this wonderful course.
Okay, thank you to share our IBD edu course this 7th wave. And we are one of the key person in IBD in globe, as we said all time. And with all respect, we are introducing you to this lecture. I know that you are at the early morning now before going to work, but I know that all of us waiting for your interesting talk. Let's go directly to your talk, please.
Thank you. Let me make sure I know how to share my screen. All right, can you see my slides?
Yes, welcome, as we said.
Fantastic. All right, so my goal this morning is to review with you the management of acute severe ulcerative colitis, what we used to call fulminant colitis. So these are our patients with ulcerative colitis that are in the hospital because of a severe flare. So I thought we could start with a case really to highlight some of the patients that we would see in the hospital. This is a 25-year-old woman. She used to be a smoker. A few years later, after she stopped smoking, she developed ulcerative colitis. And it's a pancolitis involving the entire colon for the last 2 years. She actually has been doing well on mesalamine and mercaptopurine. Sometimes she has minimal symptoms that are controlled with budesonide. But now she comes to my clinic with a complaint of 10 bloody bowel movement per day, urgency. She lost a few pounds during the last few weeks. And on history, she does not have any travel history. Now with COVID, nobody's going anywhere. And no history of taking antibiotics. She sometimes take anti-inflammatory for joint pains, but she's been in high stress with work and kids at home, etc. So we give her prednisone 40 milligram, but she does not improve. And now she's having a mild fever and she feels dehydrated and tachycardic. So what I really want to review with you is when we are assessing a patient with ulcerative colitis, how do we look at their disease? First, it's important to see how is our patient doing today? What is the disease activity now? What are the acute symptoms, whether the GI symptom, but also it's important to remember non-GI symptoms. So a patient coming in with a flare, but also with joint pains or with a uveitis, it's important to assess these things quickly, and they can be a sign of severity of what's going on in the bowel. And also we do need objective markers of inflammation. So again, a patient coming in with a flare, it's important to assess their CRP or fecal calprotectin, because that can give us a sense of how severe the inflammation is or is going to be. It's important to remember that often CRP and fecal calprotectin are predictor of how the disease is going to evolve, are predictor of flares, are predictor of how much the severity of the symptom can evolve. But also it's important to listen to the patients. This is what we call patient-reported outcome. Some patient might have 4 or 5 bowel movement per day, so we would think of them as not having too much of a severe flare. But if it's debilitating, if they're not able to go to work, if they're not able to get out of bed, if they're always in the bathroom, if they're afraid to leave the house to go grocery shopping or pick up their kids from school, this is important to take into consideration. And this is a marker of severity. So we see the patient, what are the GI symptoms, what are the extraintestinal manifestation, our objective marker, and how is the patient feeling and doing. Then it's important to look at their history. What has been going on before? If these are patients that have been under amazing control for a long time, we look at these patients differently than if this is a patient that has a history of having severe flare that require hospital stay, if this is a patient that traditionally does not respond to oral prednisone. So it's really important to see how their disease has evolved up to this point in assessing their disease severity. And finally, putting all this together, what is the risk of colectomy in this patient? What is the risk that we will not be able to control the disease if we don't control the disease quickly? What is the risk that this patient will go for surgery? So young patient who have extensive disease, if patients have had recent scope or at the initial scope of diagnosis, you have seen deep ulcers, this tells you this patient can progress very rapidly toward fulminant colitis and the need for surgery. If a patient has a history of being in the hospital, of having C. diff infection, CMV infection, again, that put the patient at risk of colectomy. So keeping these things in mind, let's look at the new ulcerative colitis activity index that was put out by ACG. If you remember the traditional Love-Hewitt activity index, we focused on number of bowel movement per day, blood in the stool, hemoglobin, and sed rate. In the new activity index put out by the ACG, one more clinical symptom was included, which is urgency, which we know is a big distressing symptom for our patient, the need to constantly go to the bathroom, but also it is a marker of the severity of the inflammation in the rectum. Severe proctitis will give you great urgency. And so it's important to listen to the patient telling you, I go 15 times to the bathroom, but most of the time it's just a little bit of blood, a little bit of air. I have 3 or 4 bowel movement per day. Otherwise, that urgency is a marker of severe inflammatory burden of the rectum mainly. But also in addition to sed rate, which we know can be elevated if we have anemia or for other reason, CRP was added, but also fecal calprotectin. So fecal calprotectin is our inflammatory marker in the stool. It's a marker of inflammation in the colon, and it's more specific to bowel inflammation than a CRP. Unfortunately, fecal calprotectin takes several days to come back. So we still rely on the CRP as a marker of inflammation. It's a quick lab that comes back, but it's also fecal calprotectin is more specific, more sensitive. So for example, if you have somebody in a flare, but also have joint pains, the CRP can be very elevated because of the joint inflammation, the arthritis. The fecal calprotectin will give you a better sense of what's going on in the colon. And also it's important to remember that some patients with inflammatory bowel disease don't mount a CRP response. The CRP can remain normal, and you really have to rely on the fecal calprotectin to assess the inflammatory burden in the colon. But very importantly, what was added to the activity index is what we see on endoscopy. So, a few years ago, we just rely on symptom and some labs, the hemoglobin, if there's anemia or not, the inflammatory markers, CRP and sed rate. But it's important to remember that the endoscopy score is very important in telling us how severe the disease is, and whether you're using the Mayo score or the UC EIS, whatever you use in your practice. When you're doing an endoscopy report, make sure you use that, because then that helps you, if the patient transition care to another physician, to another location, you know that this patient had Mayo scores 3 at some point or Mayo score 2. So you know that this is a patient that have a more severe disease to be taken more seriously. So our patient here with 10 bloody bowel movement per day, with also some mild temperature, and it definitely belongs to the moderate or severe or even fulminant ulcerative colitis. And that helps us assess if this is a patient that needs to be in the hospital. Anything moderate, severe, fulminant, this is a patient that needs to be admitted. Or if this is a patient you can treat as an outpatient if they have more mild disease activity. or that you could treat, with a close follow-up in clinic. So our patient belong to the hospital, but it's always important when a patient with UC has a flare, whether this is a patient that belongs to the outpatient clinic or to the hospital, to assess the cause of flares. And flares could be due to many things, whether it's non-compliance, this patient was on mesalamine and mercaptopurine, and we know that patient compliance with oral medication is not great. We all forget to take a medication every day. So in a situation of stress, there's a higher risk of being non-compliant, but patients often report that stress can trigger a flare. And if you look at the old literature, and when we were in med school, they would tell us, oh, stress has nothing to do with IBD flare, but it does. Our patients tell us that it does. And now understanding the gut and brain axis and the gut microbiome, we know that stress actually changes the gut microbiome and triggers inflammation. NSAIDs can trigger a flare, but also it could be just a natural history of the disease. These are diseases that are unpredictable, and a patient who has been doing well for 2 years can suddenly find themselves in the hospital with a severe flare. But it's the most important thing to do always is to rule out infections. And whether these are bacterial infection or C. diff or CMV, it's always important to rule out infection. The most common infection we're seeing now as a cause of flare for UC or Crohn's disease is C. diff infection. But also it's important to remember that Salmonella and Shigella can actually cause a flare. And if you scope these patients, the colon can look exactly like a UC or Crohn's flare. So I always send a stool culture, a C. diff. And in a patient who's hospitalized, especially if they have been on prednisone and not getting better, it's important to think about CMV. So let's go over that. So C. diff in recent years has been really highlighted as a complicating factor that triggers a flare in a patient with IBD, and that we see more and more in a patient with IBD that are admitted to the hospital. So if you look at that curve, the top curve, we see that in recent year, we see more and more C. diff, and including mainly in patient with ulcerative colitis, but also in patient with Crohn's colitis. So always check for C. diff in your patient admitted with an IBD flare. C. diff can cause up to 20% of IBD flare, and the demographic of C. diff in IBD is different than what we see in the general population. So typically C. diff is something that we see in older patient, in nursing home patient who have been in the hospital, patient who have taken antibiotic. But in patients with IBD, C. diff can occur in the young, without a history of antibiotic. These are patients that are out in the community. But what we know as a risk factor is steroid use. So patients on steroid have a 3-time higher risk of developing C. diff. And in contrast, patients on biologic are not at increased risk of C. diff. So this is always very important in any discussion that we have. And Professor Izzat Ali mentioned that also in his talk, that steroid is always the worst treatment that we can give to our patient. This is really the medication that is associated with a higher risk of infection and morbidity and mortality. And that's a discussion important always to have with our patients that are afraid to take biologic, that actually biologic, by putting their disease in remission, decrease their risk of infection. We see C. diff more commonly in patients with colon disease, so ulcerative colitis or Crohn's colitis, but important to remember that we can also see it in our patient who had a colectomy and a pouch, or colectomy with end ileostomy. So C. diff and IBD can exist in the small bowel and in the pouch, something to remember. So how does the colon look in C. diff with IBD? So on your left is a C. diff in a non-IBD patient, where you recognize those thick pseudomembranes of the colon. As soon as you put the scope in, you know this is C. diff. In our IBD patient, 90% of the time, there's no pseudomembrane. It will look exactly like a UC flare. So the lack of pseudomembrane does not mean that there's no C. diff, so we shouldn't be fooled. So it's our stool study that will tell us if this patient has C. diff or not. Why is it important to diagnose this? Is because C. diff severity in IBD patient is much higher than non-IBD patient and increase the risk of colectomy. So your ulcerative colitis patient with C. diff in the hospital has a 6-time increased risk of colectomy than if they do not have C. diff. So these are patients that we need to treat quickly, that we need to watch, that we need to have surgery on board in case they don't do well. Also, our patient, IBD patient, has a higher recurrence rate of C. diff within the year, and their risk of death or colectomy after being hospitalized is increased at 5 years. So our patient with IBD who had C. diff once, even if we treat them, this is always going to be a marker of severity for them in the future. So when you assess them later, if they have a flare or etc., this is already a patient that you can mark as potentially having recurrent C. diff, potentially needing colectomy in the future. But the trick here also is that IBD patients are often asymptomatic carrier of C. diff. So around 10% of IBD patients can carry C. diff and not be symptomatic, which brings us to the point of when we're diagnosing C. diff, it's important to try to differentiate if this is an active infection that needs to be treated, or if it's just a colonization and the symptoms are actually only due to an IBD flare. Which brings me to the importance of what tests we are ordering, okay? So it's important to order the right test. There are many tests for C. diff. The GDH look for the organism. It tells you the organism is there, whether it's producing toxin or not. If your GDH is negative, you don't have the organism, there's no C. diff. If your GDH is positive, we need to know if the toxin is produced. And this is where we use the ELISA test. If the ELISA test is positive, then this is C. diff and it needs to be treated. If the ELISA test is negative, this is when we should do PCR. And if the PCR is positive, then we should treat for C. diff. So the best combination of tests is a GDH with ELISA, reflex if the GDH is positive. Unfortunately, many hospitals and many labs will only do the PCR. And the PCR positive just means that we have the genetic fragment that makes a toxin, but it's not the toxin. It's the ELISA that detects the toxin. So PCR only being positive could be colonization. Now, in the right clinical context, we should treat if the PCR is positive. If that's the only test that we have available, we should treat. But it's important to know your test so that if you have a patient with like PCR keep coming back positive, that might be just colonization and not infection. So what do we do? If there's a high suspicion, if I admit a patient who has a history of C. diff in the past with a flare, I'll send the stool test and I will start treatment for C. diff. Don't wait for the stool test to come back. If there's a high suspicion, start your C. diff therapy. The recommendation now is to use vancomycin. We do not use metronidazole anymore. Metronidazole has a high failure rate, so it's important to use the right therapy, which is vancomycin, 125 milligram, 4 times a day, traditionally for 14 days. But we're having more and more data. David Rubin looked at that, and there's more and more data that our patients with IBD need a longer duration of treatment. So if I'm seeing a patient on the outpatient or the inpatient setting, and I start on vancomycin and they respond, I use for at least 3 to 4 weeks, okay? So more than 14 days, more than the traditional C. diff treatment. If they have severe C. diff, if this is your patient in the ICU, they're in shock, that's the only time that there's an indication to use a higher dose of vancomycin in combination with IV metronidazole. So oral vancomycin with IV metronidazole. And if this is the patient is sick like this, surgery need to be on board. These are, again, patients that are high risk of needing surgery and colectomy. All right, so how about you have your patient, they're flaring, they have C. diff. Should we treat the flare also or only C. diff? I just told you that steroid increase the risk of colectomy with C. diff, increase the risk of mortality when we have C. diff. So what should we do? The ACG guidelines from a few years ago said when we have a patient with C. diff in the hospital, we should avoid using steroid or anti-TNF for 72 hours and use these 72 hours to treat for the initial treatment of C. diff. However, a more recent study, the IBD remedy study, which is a multi-center study retrospective of multiple hospitals in New York, looked at C. diff and IBD, and they looked at the 90 days clinical outcome of IBD with C. diff in more than 200 patients. And they looked at patients that had treatment escalation, meaning that in addition to treating their C. diff, they received anti-TNF. And they looked at patients where only C. diff was treated and escalation to anti-TNF was delayed by more than 13 days. And this is what we have. look at the column of no escalation. So these are patients that got treated for their C. diff, and we waited to treat the underlying IBD flare. And then next to it, we have the patient that were quickly escalated to anti-TNF to treat the underlying IBD flare. And death, sepsis, colectomy, and overall severe outcome was higher in patient where we only treated the C. diff and delayed the escalation to treating the underlying IBD flare. So from this study, this is what I do. If I have a patient who gets admitted with a severe UC and has C. diff, I start C. diff treatment. If there's no improvement after 48 hours, I escalate. So typically this is anti-TNF or steroid, or a combination of both. And if the patient does well, perfect. We complete the C. diff treatment, again, more than 2 weeks for most of our patients, and taper off the steroids. If the patient is improved after 48 hours, then we just focused on the C. diff infection. This is a trigger, and we don't have to treat the underlying IBD flare. How about FMT? You have your patient with C. diff. They're not improving with C. diff therapy. They're not improving with underlying IBD flare. Should we use FMT? And the results are controversial, but most of the time what we have, these are small studies, and also the way the delivery and the type of stool that was used are all different, and the number of FMT is different. But overall, if you look at these studies, patients do improve. The C. diff is around 80 to 90% with FMT, and there were no patients that flared who had Crohn's disease because of FMT, and only one of the 23 patients with UC flared with FMT. So FMT is something to consider if your patient has recurrent C. diff and they're admitted again for C. diff and an IBD flare, and you can get them better, think about FMT. How about CMV? This is a conversation we had on Monday Night IBD on the Twitter handle about IBD and CMV, and there were a lot of discussion, and this is the algorithm we came up with. Basically, most of us as adults have a positive serology for CMV. So serology is not very helpful unless it's an IgM serology. So you have IgM positive, meaning it's a new infection, but typically in our patients with IBD, their serology is going to come back positive. So we cannot rely on that part. So what we're going to focus on is a FlexSig with biopsy. So in your patient with severe UC being admitted, especially if they've been on steroid, they are high risk of having CMV. This is what we're going to do. We're going to biopsy, and typically where CMV live is at the center of an ulcer. So if on colonoscopy, and actually you don't need to do a full colonoscopy, on FlexSig for a UC patient, you see deep ulcers, you want to biopsy the center of the ulcer and send for immunohistochemistry. If the pathologist see viral inclusion or cellular changes compatible with CMV, then you know you have active CMV, and you need to be calling your infectious disease colleague and start treatment. All right, so let's go back. Now, this was all the background. We have a severe patient. We're thinking infection. We're on day one. They come in. We check baseline labs, albumin, which is a marker of severe inflammation if it's low, CRP. We send fecal calprotectin, but knowing this is going to take a few days. So fecal calprotectin is really for later, looking at the progression later, but CRP is what we can get quickly. And I always send off, if the patient has never been on anti-TNF, like my patient here who was on 6-MP and mesalamine, I send off labs in preparation for using anti-TNF. So our hepatitis B serology and a quantiferon gold to check for tuberculosis. I now moved away from checking a PPD because PPD is not very reliable in someone who's already on prednisone or steroids. It can be falsely negative. And also it relies on the fact that we have to do a read after 2 to 3 days. So we do send the labs for quantiferon gold to check for tuberculosis. And again, very important to send stool studies, including C. diff. Don't wait for the C. diff result. If you have a high suspicion of C. diff infection, start treatment. And a FlexSig with biopsy need to be done within the first 24 to 72 hours of admitting the patient. So these are the new recommendations that we really need to be early on top of things. How do we treat our patient with acute severe UC in the hospital? We need high dose steroid. So pick the one that is your favorite. I use methylprednisolone at 60 milligram IV daily, but you can also use hydrocortisone 100 milligram 3 to 4 times a day. The reason I say it's important to be consistent, because what I've seen, unfortunately, sometimes with our fellow or resident, they use methylprednisolone 3 to 4 times a day. So methylprednisolone is once a day, hydrocortisone 100 milligrams 3 to 4 times a day. Pick one that you're comfortable with and use it. In addition to that, it's very important to think DVT prophylaxis, including in our patient coming with a UC flare and bleeding. Using heparin sub-Q is not going to increase bleeding in our UC patient. UC patient with a severe flare, they have a higher risk of clotting, of developing DVT in the lower extremity, or splenic vein thrombosis, mesenteric vein thrombosis, and PE. So all the patients admitted with a severe UC need to be started on DVT prophylaxis. It will not increase their risk of bleeding. How about antibiotics? We used to put patients with a severe UC on antibiotic, typically Cipro and metronidazole, but we just talked about how they are high risk of C. diff, so we do not want to add antibiotic if we don't need to. The most recent ACG guideline recommend against antibiotic in a severe flare unless the patient is in sepsis and not doing well. In my practice, I have to say that I have seen that using antibiotic, if the patient does not have C. diff, decrease hospital duration, and studies have shown that using antibiotic does decrease hospitalization duration. And in my patient who are tachycardic and with a fever, I do use antibiotics if C. diff is negative. And I feel that that decrease the bacterial translocation from the bowel into their stream and make them feel better. One reflex that I often see in our resident is that we put everybody on bowel rest, NPO and TPN, and we shouldn't be doing that. Our patient can have diet as tolerated. There's no need for bowel rest unless they're coming in with severe hemorrhage or toxic megacolon and they're going to go for surgery. This is when you put them at bowel rest. But otherwise, if you tell them not to eat, the next day you're going to come in and they're going to say, I only had 2 bowel movements. So you're going to think they're doing fine. You'll discharge them. And then they call you from home that they're back to having 10 bloody bowel movements per day. So diet as tolerated, a soft diet, whatever they feel like eating. In terms of managing pain, it's important to avoid opioid and morphine and dilaudid that can really increase the risk of a megacolon. And it's important to monitor our patient with serial exam, monitoring for toxic megacolon, where the colon is large and when the patient develop sign of toxicity. When do we reassess? It's important to reassess very quickly, as early as day 3. By physical exam, what are the number of bowel movement per day? What is the blood in the stool decreasing? Is the CRP dropping? So I usually check all this at day 3. I repeat the CRP. And this is how we're going to assess if our patient is moving in the right direction. If all this is improved on IV steroids, then the patient can be discharged on oral prednisone, and then you can manage the rest on an outpatient basis. You can decide if you're going to change therapy, if you're going to change from a non-biologic to biologic, if the patient was already on biologic, if you're going to change to a different mechanism of action. But if the patient is not doing well, like my patient, still having multiple bloody bowel movement per day, CRP still elevated, not tolerating PO intake, then we need to do something different. So what's next? Always have your surgeon on board. If your patient is not doing well by day 3, call your surgeon. You might not need them, but they need to be on board. And actually, it's even better to call the surgeon from day 1. Just let them know about the patient. Let the patient know that we're going to have surgery on board. It does not mean you need surgery, but it's important to have the whole team on board. So if the ulcerative colitis does not respond, if you develop toxic megacolon, if there's severe colonic hemorrhage, the surgeon already know you, talked to you, and went over things with you. So it's not a surprise. We're not rushing the patient to the OR without prior discussion. And now this is the time to escalate therapy. And we have traditionally 2 choices, infliximab and cyclosporin. But now also we can think about tufasitinib as an option, and we'll go over that. So just let me refresh your mind about the risk factor for colectomy. If this is a young patient, if they were non-smoker or ex-smoker, if they have fever, if they have peripheral manifestation, if they have high CRP, low hemoglobin, low albumin, all these are criteria of severe disease. If when you did FLEXIG, you saw deep ulcers, if they have CMV or C. diff, these are high risk of colectomy. You need to have the surgeon on board. So let's look at our two traditional options, IV infliximab or IV cyclosporin. For IV infliximab, typically 5 to 10 milligram per kilogram for the first dose. If they respond after the first dose, fantastic. They can be discharged on infliximab, and then you can add immunomodulator with it or not. For IV cyclosporin, you need to use it with steroid, and if we induce remission, then they can be transitioned on outpatient basis either to azathioprine if they've never been on azathioprine, or now to vedolizumab. If your patient does not respond to infliximab or to cyclosporin, this is a time for colectomy. We don't go from one to the other. So if your patient failed IV infliximab, going to IV cyclosporin is very high risk of infection and mortality, and vice versa. So you have to pick one or the other. So for infliximab, the studies that we have in acute severe ulcerative colitis show a response rate that varies between 50 to 100%, depending on the cases and depending on the dose. And those that have been used vary from the traditional 5 milligram per kilogram up to 20 milligram per kilogram, with the idea that patients who have severe disease, low albumin, a high CRP are going to lose protein in their gut and lose infliximab also. So that is why often in our patient with acute severe UC with low albumin, high CRP, if we're going to use infliximab, we're going to use a higher dose, 10, 15. I have never used 20 milligram per kilogram, but some have, but use a higher dose so that the patient can retain some infliximab and make it effective. The colectomy-free survival with infliximab is 70% at 1 year, okay? So now, is there any benefit in our severe patient to give them one dose and then instead of waiting 2 weeks later for the second dose, if they don't do well, to give them another dose at 5 days and another dose at 5 days? The data actually has shown that there's no benefit to accelerated dosing regimen. So when we collect the entire data, retrospective data on those that had an accelerated regimen, where after the first dose in the hospital, they didn't do well, we gave them a second dose 5 days later, it does not seem to delay or decrease the incidence of colectomy. So I think we need to be very selective in who we're going to do that for. And sometimes delaying surgery by keep giving infliximab, we are doing a disservice to the patient and making them sicker, and then poorer candidate to surgery and a high risk of complication from surgery after being malnourished and on steroid, on infliximab for many days before sending them to surgery. So use an accelerated dosing regimen judiciously in the patient that you feel is getting better, but not perfect yet. These might be the ones that benefit from accelerating dosing. How about IV cyclosporin? Think of cyclosporin in your patient that you think would not respond to infliximab. So your patient with low albumin, high CRP. So, but also you need to be in a center and be comfortable using IV cyclosporin. It's used as a continuous drip in addition to steroid. Trough level has to be checked at 48 hours, and the goal of the trough level is between 300 and 400. And you should put your patient on a PJP prophylaxis, what we used to call PCP prophylaxis with Bactrim. And cyclosporin, as you know, has many potential side effects, including seizure and renal toxicity. So you really want to monitor the patient very carefully. But in terms of result, it has similar result than infliximab. Around 60% will avoid colectomy at 1 year. If the patient responds to cyclosporin, then you discharge them on oral cyclosporin. They're going to be on it for several weeks with a steroid taper. And then as you're tapering off steroid and you're getting ready to stop cyclosporin, your exit strategy of azathioprine or vedolizumab can be started. How about tofacitinib? So tofacitinib has been approved for UC at a dose of 10 milligram twice a day as an induction dose and maintenance dose of 5 milligram twice a day. There are small case reports that use tofacitinib in acute severe UC, mainly a great option in your patient who's already on infliximab. If your patient is already on infliximab and now they're failing infliximab and they're here with severe UC and they don't respond to steroid and you don't want to send them to surgery, tofacitinib can be an option used at higher dose. So in those small case report, it was used as 10 milligram twice a day or 3 times a day or 15 milligram twice a day. So higher dose around 30 milligram per day. And in this small case report, there was rapid improvement of symptoms, a drop of CRP, and patients were able to avoid surgery. So something to think about in your practice, if you have someone who already failed infliximab, you do not want to use cyclosporin, and you want to try to avoid surgery, this might be a good option. All right, so I'm gonna summarize quickly. When we are dealing with a patient with UC, assess disease severity now. What was their history up to now that tells you that this patient could be at risk of needing colectomy and we need to act quickly? And recognize the disease severity now and the risk of colectomy historically, and decide if this patient belongs to the hospital. Once your patient is in the hospital, make sure there's no infection, mainly C. diff. If positive, oral vancomycin is now the treatment of choice. Check your baseline labs. Albumin, hemoglobin are a marker of severity. And check your infliximab prereqs of hepatitis B and TB if your patient has never been on infliximab before. Do your FlexSick within 24 to 72 hours to rule out CMV. DVT prophylaxis is very important. People often forget about it or are worried about it, that it might cause more bleeding. It doesn't. So put your patient on DVT prophylaxis. Start high-dose steroids, serial abdominal exam, repeat assessment in 3 days. If CRP and symptoms are not getting better, move on to plan B. Antibiotic, maybe, in certain patients, and then PO intake as tolerated. If there's a failure of steroid after 3 days, have your surgeon on board, choose your next therapy, and if your next therapy is not improving the patient, do not delay surgery. The more our patients are sick and malnourished, the more we have surgery complication. And unfortunately, you know, some patient, a proportion of patients, despite all the therapies that we have, will still require surgery. If their response to infliximab, they are maintained on infliximab. If their response to cyclosporin, they transition to a maintenance therapy. If they respond to TOFA now, they will stay on TOFA. So I'm going to stop here and tell you that IBDologists are cool people and they act fast and strong. And it's important to remember to do that in our patient with active acute severe ulcerative colitis. Do not delay effective therapies.
Welcome again, Alan. We have to know that this elegant lecture from our Professor Alan Sharapati, that is a clinical director of gastroenterology division, director of IBD Center at Johns Hopkins School of Medicine. She has the very creators for the IBD. She created what's called Monday Night IBD as the Twitter. She has Play Rule and a very good, strong platform for all IBD interested people, and they play a role as an advocate and helping a lot of advocates in the IBD to play a role. Also, she is the chair of Greater Washington, D.C., Virginia Crohn's and Colitis Foundation. Also, she received the Excellency in the Medicine Award, CCFN 2020. I think we are proud to hear you and to listen for this elegant lecture. And I think you have a lot of questions before going work now. Yes?
Thank you, Professor Ali, for this very nice introduction. And I'm going to tell you, I am so, you know, the one thing about Twitter is that we were able to connect with an international community and share experiences and learn from each other. And we always appreciate your input on Monday Night IBD. And I think the biggest pleasure I have is really connecting with amazing people that are working into raising awareness for IBD and providing the best care for our patients.
The first question is a COVID-19 zone question. You know that is some cases of COVID-19 showing some IBD-like features. And what about how to deal with, how to think, how to expect that is predominant COVID than IBD or UC flare?
This is a great question. And if you probably are aware, there's a registry, the Secure IBD registry, that has been collecting data on patients with IBD that have COVID to better understand how COVID affects patients with IBD. So what we know now is that COVID can manifest with GI symptoms of diarrhea and vomiting. And more so in IBD patients. So if your IBD patient presents with symptoms that are not typical of their flare, so if your patient typically has pain and blood in the stool, and now suddenly they also have vomiting and fever, you have to think this could be COVID. If they also have other symptoms of fever or they had contact with someone who had COVID, you have to think COVID. Now, how do we treat that? The recommendation is that depending on the therapy, we either hold it or keep it. So, but and this is a theory, because in practice, even if you hold thiopurine or if you hold infliximab or ustekinumab, the effect of these drugs are still in the patient body. So if the patient has COVID infection and they're due for an infusion or an injection of a biologic, you can hold that for a couple of weeks until they get better. But if you're on budesonide or on vedolizumab, you can proceed. The data that we have now is that we can continue these kind of therapies. If your patient has an IBD flare and a COVID infection, it's important to treat both. And there's more and more case series showing that actually controlling the IBD flare is important, and even maybe using anti-TNF can actually help with the cytokine storm of the COVID-19 infection. So I think it's a very tricky situation, and where you have to balance the risk and benefit and adjust to the severity of the COVID and the severity of the IBD flare. If the COVID is mild, I usually don't change anything. I keep everything the same. If they're due for an injection or infusion, I delay by a couple of weeks. There's no big deal. If the COVID is severe and the patient is in the hospital, we focus on support care of COVID. But if the IBD flares, we have to treat the IBD. And then it's important to remember for our patient that it is being on steroid and have active disease that put the patient with IBD for severe COVID infection. Being with a secure IBD registry show us that being on anti-TNF, ustekinumab, or vedolizumab does not increase the risk of severe COVID. They do better than patients who have active flare or on steroid or even patient on mesalamine. So it's important now more than ever to tell our patients with IBD to stay on the medication that's keeping the IBD in remission and not stop the biologics, and continue to do well and stay away from the hospitals.
Before I'm shifting to the second question, just say welcome, Professor Hussein Al-Amin is my second chair in our guest lecture. Welcome, Professor Hussein.
Welcome, my dear friend.
Okay, I have Dr. Momin had a question for you, Professor Allen.
Professor Allen, you are welcome, and thank you for this excellent lecture and topic. I have more than one paper, multiple papers about the high dose of infliximab in ASUC, which is better than the lower doses using 10 milligram or 15 milligram, as you mentioned in your lecture. But I'd like to ask you, the risk of colectomy is less in the high dose of infliximab rather than the low dose, but after 1 year, we have higher risk of colectomy in patients with ASUC after induction of remission and maintenance with infliximab. Do you recommend shifting the patient to other biological therapy rather than anti-TNF after using it as a bridging therapy in ASUC in order to decrease the risk of colectomy, or once you have patient in remission, maintain him on infliximab and monitor him? And thank you so much.
This is a great question. And again, thank you all for having me. It's really a pleasure to be here. So I agree with you. In my patients hospitalized with UC, if I'm going to use infliximab, I usually use 10 milligram per kilogram because they are sick, they're going to lose the infliximab. 5 milligram is not enough. The controversy is whether or not accelerating the frequency every 5 days in patients who don't respond to the first one, is it beneficial or not? And the data is not there. But I agree with you that 10 milligram per kilogram is my choice. When a patient is having severe UC and requiring higher dose of infliximab to get better, they're already telling you they are at high risk of colectomy. And like we saw in the data, it might delay the colectomy, but they might still need it. But honestly, I don't think of it as a total failure of our therapy, because it really prepares also the patient to the possibility of a colectomy. It's very hard for a patient admitted with an acute flare, sometimes this is their first flare, to just being rushed to the OR on that admission. So I think what's important here is to tell the patient, you have severe UC, we got you better on infliximab, but your disease is telling us this is a severe disease. We might still need surgery, but we'll see what happens. Mentally and psychologically for the patient, they will be better prepared, but also in terms of nutrition and physical status, we improve their overall state, and that would decrease the risk of complication for surgery later on if they need it. On the other, the patient who require a high dose of infliximab,
تعالي والنبي يا بسمة.
I'm going to keep a very close eye on. So these are the patients I'm going to monitor the infliximab level during maintenance and make sure they are at the right level, somewhere around 10 of trough level. And I'm going to monitor their markers of inflammation. This is a patient I'm going to monitor fecal calprotectin every 3 to 4 months. So if I see that the calprotectin is increasing, I know I need to do something different because this is a patient at high risk of colectomy. The third thing we can do is combine effort. And in addition to infliximab, have the patient also on thiopurine, on azathioprine or 6-MP, whichever is your favorite, and combine therapy to really optimize our control of the disease. Now, should we switch to something else? Honestly, infliximab is the one that is a biologic that is the most effective one that we have.
The best, yes.
Right. So in our sick patient, if you ask anybody with GI or IBD, in the sickest patient, we're going to use infliximab. If infliximab doesn't work, there's less risk for the other stuff to work, especially in the severe cases. So if our patient responds to infliximab, I will optimize infliximab by following trough level, adding an immunomodulator, following fecal calprotectin or CRP, and adjust accordingly. And always have that discussion with the patient. The patient, we don't want to make them anxious that they are in a bad place, but we want to be objective and prepare them mentally that, we're going to do our best, but it's always important to remember there's a patient that still needs surgery, and it's okay. And it's better than being sick the rest of your life. So always that communication, monitoring, and reassessing.
Thank you, Professor Alan. Thank you.
Professor Izzat, I want to ask a question, please.
Yeah, go, Professor Hussein.
Hello, Professor Alan. Welcome to you. And thank you for a very, very nice presentation. I have actually a real case last month, a female patient, 50 years old. She came with acute severe ulcerative colitis. She gives a history of treatment of steroids for many years. And also she had a partial response to Simponi. This patient came with acute severe colitis and received IV steroids. Unfortunately, after 3 days, she developed 2 perforations in the left colon. And the surgeon did for her ileostomy because of the very bad general condition. The patient is now very good on oral steroids now, 25 milligram. What do you think is the future plan of this patient as regards he gives a history of partial response to Simponi? What's the future plan for this patient with ileostomy and history of 2 perforations in the left colon?
Okay, so this patient is high-risk colectomy, right? She's been steroid dependent.
Yes.
She had a spontaneous perforation of the colon, which also have to make you think about 2 things. And that would be great to have some surgical specimen. And I don't know if the surgeon took out some of the colon that was perforated or not, and to examine the specimen well to make sure it's not Crohn's disease. So I need to have UC with perforation. It could be severe UC, but also it could be Crohn's. And we know that in some patients it's difficult to differentiate between the 2, especially when you have not made the diagnosis. It's a diagnosis made a long time ago. We really don't know what was there. So this is a patient anyway already in the severe category. And I think in this case, it's important to have what we call a shared decision, meaning discussing with the patient the option and the pros and cons. If we think this is ulcerative colitis and she had perforation, I would be very inclined to say we're going to do a colectomy and an ileal pouch. And what you can do actually is do that in stages, do a colectomy and leave the rectum, have the opportunity to examine the colon, make sure this is ulcerative colitis and not Crohn's, and then take it from there. Or you can tell the patient you had a partial response to Simponi, and maybe something like infliximab will get you better. And we can consider, resuming biocontinuity and doing infliximab and see how you do. But there's a risk that we're not able to control things and you will still need surgery. So there's no right or wrong answer. I think it's very important to always think about the patient first before the colon. We're trying to save the patient and keep them alive and not have them have another bioperforation. And this time she did fine and she survived. Next time she might not. So it's always important to think that it's the patient we want to do well and not necessarily the colon. But if we're going to offer surgery, it has to be also the right surgery and make sure that we're doing the right surgery if it's UC or Crohn's disease. So it's important to have this kind of conversation and to think about it. There's no urgency now. Well, I think the fact that she has a diverting ileostomy, we can taper off the prednisone so that whatever decision we make, if we're going to go for surgery, she's on the least amount of prednisone, since steroids can increase the risk of complication from surgery. And since the bowel is diverted now, her colon does not need the steroid. So we can taper down the prednisone and then reassess. Maybe you can scope her, take a look, take some biopsy, get a sense of what's going on. But I think both options are there. She already manifested that she's high risk of colectomy. If she has UC, she already perforated on her own. Doing a colectomy and an ileal pouch is a good option. Or you can say you had a partial response, but also you've been on years of steroids. We don't know if you're going to do better on infliximab, but you could do better on infliximab, and we can do this option. So both options are good. And it's important to have that decision with the patient, because patient might say, you know what, I don't want to ever deal with this being in the hospital and think I'm going to die. Get that colon out, I'm done. Or the patient say, no, I want to try everything, but it's important to have realistic expectations. Things might not work and we might still need surgery.
Thank you.
We have two final questions, one from Dr. Nada Osman, one of the IBG EGU member, and the second from Dr. Dua Haider. Starting, Dr. Nada is also Dr. Dua, one of the IBEGU platform. Dr. Nada, start your question.
Welcome, Dr. Allen, to our 7th EDU wave. I have a question about COVID patients. You are going to continue his biological therapy. Azathioprines, you're going to stop them while the patient is having COVID. When you're going to tell your patient to continue his azathioprine therapy?
It's a great question. And first of all, can I say how excited I am to see so many women on the panel? So you guys are amazing, and
Yes.
it's fantastic to see this. Yes. Really, it's beautiful and it warms my heart. And it's, I just want to congratulate you on that.
Woman at diversity, yes?
Yes. I mean, I feel the power here. Yeah. So in the Secure IBD registry, they published their data recently that patients on azathioprine or mercaptopurine might be at higher risk of severe COVID. And we know that thiopurine increases the risk of viral infection, so it kind of makes sense. So the recommendation now is that if we have a patient on combination therapy, if they are on, let's say, infliximab plus azathioprine or 6-MP, is to see if it's appropriate to remove the thiopurine and just keep the biologic monotherapy if it's the right decision. Again, it's very important, and this is as a prevention of having severe COVID, or if they have, or if they get an infection. If your patient needs both to stay on remission, it's important to keep both. Patients who have a history of very severe disease, difficult to control, and only being on both treatment help, we need to keep that on board, because the worst thing we can do is have the patient flare and need steroid. But again, if they're on combination therapy and they're stable and you can remove the thiopurine, we'll remove thiopurine. Now, if they are on thiopurine alone and they develop COVID, we know that even if we stop thiopurine effect lasts 2 to 3 months, right? So we stop it, but it doesn't really mean much because the effect is still there. If it's mild symptom, I don't stop it, honestly, because I don't want the patient to flare. I don't want to have to use steroid because that will put them at higher risk. If they are in the hospital, I stop it, but and we stop it a little bit, it's like a psychological benefit for us because the effect is still there. In our outpatient that are on thiopurine and they come to you and they're concerned that maybe that can increase the risk of severe COVID, you can assess and see if they are candidate for another therapy or stay on the thiopurine, because that's, it's all about risk and benefit when we are trying to make these decisions. If a patient is doing well on thiopurine for years, I'm very reluctant to stop it and say, let's try something else. What if something else doesn't work? So it's a risk and benefit discussion, and this is where you discuss that with the patient and see how they feel about it, because they need to be partner in that decision and understand the risk and benefit of switching from a therapy that worked to something else, and the risk of if they get COVID, they might have more severe COVID. Does this answer your question?
Yes. Dr. Dua, ask the question, Dr. Dua.
Okay. Thank you, Dr. Allen, for this elegant lecture. And I have two questions. First question is, biosimilars, do they have a role in acute severe ulcerative colitis management?
That's a great question, and I'm glad you asked, because there's a lot of concern about biosimilar that they might not be as good as the original. And the data that we have now is that biosimilar actually have the same efficacy than the original. So biosimilar infliximab has the same efficacy as the original Remicade. In our hospital, for example, we switch everything to biosimilar, and it's cost saving, obviously. It costs less money for the health system. And even our patients who were on the original infliximab, we switched them to the biosimilar. So that is very important to remember that they have the same efficacy, and long-term follow-up, patients on biosimilar from the start or who were switched from the original to biosimilar compared to those who stayed on the original had the same efficacy long-term, same rate of loss of response, same rate of having antibody. The thing to remember is that if you develop antibody to the original infliximab, you should not switch to the biosimilar because it's the same antibody. And the way to think about it, and what people that are smarter and like are into molecular biology explain to me, is that even if you look at Remicade, the Remicade that we had 20 years ago is already different now, because the process of making these kind of antibody, there's always a little bit of change that happen. So it's what our patients are getting now, even if they're getting the original infliximab, is a biosimilar to what they were getting 5 years ago in a sense. So if your hospital has a biosimilar version of infliximab, you would use it same as the original infliximab.
And my second question, in 2019, there was a study on 40 patients with acute severe ulcerative colitis, and they used successfully cyclosporin therapy after infliximab failure. What's your opinion about this, Dr. Allen?
Yeah, so this has to be done in a very specific center, and really, you have to really assess the risk and the benefit. And even, I think this study is from the University of Chicago, and even when Russ Cohen and David Rubin talk about this, they say it's feasible, but don't try it at home. So it's something that you could do. But again, these are patients that are telling you they have severe disease. And I think we would just be delaying the inevitable and putting them at high risk of complication and mortality. So unless you have a IBD service dedicated to that, where the monitoring is really on top of things, the patient understand the risks, and we're monitoring everything, and you have infectious disease on board and renal on board and everybody else, I personally don't like to switch from one to the other. I think if one didn't work, I would move to surgery.
Yes. Okay, at the end, thank you a lot, Ellen. But consider our IBD Edu is your platform, as one of the global platform for IBD. And next time we will meet physically, inshallah.
Oh, inshallah, I can't wait.
Inshallah. Bye, thank you.
Thank you very much for having me. Have a fantastic day. Mabruk, mabruk, mabruk on this fantastic course. It's really high quality, and I love the fact that You know, it's a diverse group, and the lectures are amazing.
Thank you a lot. Thank you a lot.
Thank you.
Bye-bye. Bye-bye.
Bye-bye.
Now we will shift to the third session. The chairperson now ready?
Yes, ready, Professor.
We have Professor Dr. Ahmed Nagih, Professor Amin Al-Banna, Professor Walid Al-Shazli, now ready for the next session. Go on. Dr. Amini, go on.
Yes, Professor. It's an honor to be with you in this prestigious IBD edu. Nice to meet you, Professor Hussein Al-Amin and Professor Ahmed Nagih and Professor Walid Al-Shazli, but I don't know where is Professor Walid. Is he with us?
No, I think Professor Salim is ready now.
Okay, so it's an honor now to introduce Professor Salim. I don't know.
Salim Ishtawi from Libya.
Salim Ishtawi from Libya, to give us a lecture on the post-operative Crohn's disease management between guidelines and clinical experience. Yes, Professor, we have the honor of having you with us. Please.
مساء الخير جميعا. سامعين الصوت؟
تمام سامعين.
تمام. أعتذر عن عدم وجود الصورة. I have some technical problems with the camera. بس أي حد يعني ما عندوش شعر تبص عليه وأنت تعرف إني أنا يعني.
أكيد عارفينك وكنت لسه منورنا الجمعة اللي فاتت بروفيسور.
الله يخليك. I'll share my slides now. Okay, so we're starting. So what I'm going to do today is talk about post-operative Crohn's disease. So I'll define the scope of the problem, and then we'll go through some of the guidelines. So we know that post-operative recurrence in Crohn's disease is a common problem. Almost half of more of patients will require surgical resection within the first 10 years of the disease, and quarter of these will require at least another resection within 5 years. Now, the endoscopic recurrence at the terminal ileum can occur in up to 90% of patients within 12 months of the first surgical resection. However, the clinical recurrence lags behind. That's why if we look at here, we see that within the first week, you can see histological recurrence. 70 to 90% of patients by 1 year, they will get endoscopic recurrence. We have to intervene in this period here. Once we see radiological features of recurrence or clinical recurrence, then it's probably too late and the tissue damage has occurred and the patient might progress to surgery. So I'm sure that you all are aware of this endoscopic scoring system, which Rutgers developed for post-operative recurrence staging. So if the patient has I0 or I1, then they are in endoscopic remission. If they have I2, 3, or I4, then they are in recurrence and they will need some sort of prophylaxis. Now, around 70% of patients at 1 year will have either I2, 3, or 4 during endoscopy, and therefore they are at risk of progressing to surgery. Those who have I0 or I1, they are the likelihood that they go to surgery is low. Now, so what are the risk factors for post-operative recurrence of Crohn's disease? There are many risk factors: patient-related, disease-related, surgery-related, histology-related, and gene-related. The patient-related factors are many as well. Smoking is one of the most important ones. Sex, young females probably are more, but no concrete data. IBD family history unclear. Then we come to the disease related. Young age at onset carries high risk of bad Crohn's disease in general, and probably post-operative, but no clear data in this setting. Duration before the first surgery, of course, short duration before the first surgery is related to high recurrence post-operative. The location of the disease, so the ileocolonic disease is less than the ileal disease in terms of recurrence. And the penetrating phenotype of disease is more aggressive and more related to post-operative recurrence compared to structuring or inflammatory disease. The perianal disease carries a high risk of post-operative recurrence as well. Now, the type of surgery also have some implications. So if the whether you do it with stapler or you do it hand sewing, whether it's a wide anastomosis, whether you keep the patency of the bowel or you make a preventive or prophylactic ileostomy. The extent and margins of the recurrence, if you excise more than 50 centimeters of the small bowel, then probably that's an indicator for early post-operative recurrence. There is no data whether laparoscopic or open surgery have any difference. And structuroplasty, some studies say that there is high post-operative recurrence with structuroplasty. Post-operative complications, not clear. Blood transfusion, yes, increases the risk of endoscopic and surgical post-operative recurrence. And having previous resection is a risk factor as well. Now, the histology-related factors include plexitis. So if you see mesenteric plexus, then that's a predictive of early and severe post-operative recurrence. Presence of granulomas as well is associated with high recurrence. Lymphatic vessel density, it's inversely related to the post-operative recurrence. Gene factors, the most important gene is SMAD, is NOD2 or CARD15 gene, which increases the risk of post-operative recurrence. Other genes are also implicated, but no clear rule for them. Now, if you look at this, this is simple stratification of the original guide to the stratify patients into low risk, intermediate risk, or high risk group. And usually in the low risk group, probably prophylaxis is not needed if the patient is willing to go that way. In the other two groups, prophylaxis is needed. So what medication we can use and why? This table shows different studies that compared anti-TNF alpha medications with azathioprine and 5-aminosalicylic acid group and also with placebo. And you can see from the results here that anti-TNF alpha had much better impact on post-operative recurrence prevention. These studies, most of them stopped after 12 months. However, the Yoshida study had follow-up at 3 years, and there was significantly higher remission rate of 93.3 on the infliximab side compared with 56.3 on no treatment side. So still at 3 years, there is benefit. There's a randomized study that compared post-operative Crohn's disease using adalimumab against azathioprine or 5-aminosalicylic acid for 2 years. And at 2 years, they found that there was a significant reduction in endoscopic recurrence for those on adalimumab compared to azathioprine and 5-aminosalicylic acid. This graph here shows the effect of infliximab compared to placebo, and again, impressive patients remained in remission. So the post-operative recurrence in the placebo group is 51%, and in infliximab group is 22%. Now, for those patients who was receiving anti-TNF alpha, anti-TNF alpha prophylaxis after the surgery will predict that they will have more relapse compared to patients who didn't receive anti-TNF alpha before having their surgery. Now we look at the booster study. Now 50% of patients were put into the standard care group, so they had no endoscopy at 6 months, and 50% of patients had endoscopy at 6 months, and they were called the active care group. Now the treatment was escalated in the active care group depending on the endoscopic Orrit grade score. So if they were on no treatment, they will receive azathioprine. If they were on thiopurines, then they will go into adalimumab. And if they were using adalimumab, they will escalate the dose or decrease, the dose interval. Now, at 18 months, the active care group, they still have 49% of recurrence, whereas the standard care group, 60% post-operative recurrence. So significant difference, but still high figure, 49% group here. So we are not doing excellent here. So at 18 months, clinical recurrence was 27% in the active care group and 40% in the standard care group, and the statistics were not significant. Now, if you compare the anti-TNF alpha with thiopurines, obviously here that adalimumab causes more remission, and there was less post-operative recurrence compared to thiopurines. Sorry. And there was no difference between infliximab and adalimumab in endoscopic, preventing the endoscopic or histological or even the clinical post-operative recurrence in Crohn's disease. What about antibiotics? Now, antibiotics, the widely used one is metronidazole, and it usually prevents post-operative recurrence at least for the first 3 months. There are lots of limitations for its use. The adherence to taking it is not great, and it is associated with peripheral neuropathy for long term, so usually given in the first 3 months. Ciprofloxacin doesn't have much effect, and there is increased interest now in using rifaximin for post-operative recurrence of Crohn's disease. So what the BSG guidelines say? So they suggest that following ileocolonic resection of Crohn's disease, we have to assess mucosal inflammation either by ileocolonoscopy, fecal calprotectin, and or cross-sectional imaging if ileocolonoscopy is not possible or not acceptable. But these are not as sensitive enough to detect the localized inflammation. They suggest that the ileocolonoscopy is done at 6 months to assess the new terminal ileum, and if it's not at reach, then we go to cross-sectional study with MR enterography to assess the new terminal ileum. The BSG also suggests that Crohn's disease patients with significant risk factors for disease recurrence following ileocolonic resection, especially if they are smokers, they should have, at 6 months post surgery, they should have colonoscopy, and they can be started after with thiopurines if they have recurrence. Those who are not tolerating thiopurines, they can go into anti-TNF alpha. They recommend that some patients who don't have endoscopic recurrence, but who has diarrhea, they have to be investigated for other causes of diarrhea, like bile salt malabsorption, and a trial of cholestyramine should be offered. If cholestyramine trial didn't work, then we might consider a CCAT study. BSG recommends that all patients should quit smoking, and they advise against the use of mesalazine in post-operative Crohn's disease. Now, the AGA goes a bit more proactive. So they advise to use pharmacological prophylaxis immediately after surgery rather than endoscopically guided pharmacological treatment. In patients with surgically induced remission of Crohn's disease, they suggest using anti-TNF alpha and or thiopurines over other agents. They also advise against use of 5-aminosalicylic acid, budesonide, or probiotics. In those patients who had surgery, whether they are receiving or not receiving pharmacological prophylaxis, they suggest that post-operative endoscopic monitoring should be done at 6 to 12 months to assess the new terminal ileum. In patients with surgically induced remission of Crohn's disease, asymptomatic with asymptomatic endoscopic recurrence, they suggest starting or optimizing anti-TNF alpha or and thiopurine over continued monitoring alone. So I talk here about a little bit of non-invasive methods to evaluate post-operative recurrence. So ileocolonoscopy is the gold standard, but ECHO says that you can use calprotectin, transabdominal ultrasound, magnetic resonance enterography, and many other emerging alternatives. So I don't have enough time to go through these, but I'll just say that fecal calprotectin is correlates well with Rutgers score, and it doesn't replace colonoscopy, but in low risk group, if you measure fecal calprotectin at 3 months after surgery, if they are positive, you might consider doing early colonoscopy. There is increased interest now in the microbiome and the presence of Proteus in the resection margin, which increases the recurrence. If you have reduced Faecalibacterium prasinetzi, then that's again another factor. So briefly, we have low risk patients or patient preference, then probably no medications or metronidazole for the first 3 months, then colonoscopy at 6 to 12 months. If they have no post-operative recurrence, then repeating in colonoscopy at 1 to 3 years. If they have recurrence, then they have to receive anti-TNF alpha and or thiopurines. If the high-risk group patients, you straight away start anti-TNF alpha according to the AGA and metronidazoles for the first 3 months. Of course, you would stop smoking. BSG adopts something similar, but before discharge of the patient, they start him on metronidazole for 3 months and ask them to stop smoking, and then they stratify the risk. If they have low risk factors, then they do ileocolonoscopy at 6 months. If they have high risk factors or likely to continue smoking, then probably you start them on thiopurine, or if they are intolerant, you start them on anti-TNF alpha agents. So what we do here in our country, it's really problematic here due to lack of data on prevalence and incidence. Many patients are diagnosed overseas, either in Egypt or Tunisia, and many of them go for follow-up there. So no good data regarding epidemiology of the disease here. In a hospital-based study that was published in the Libyan Medical Journal last year, that included 263 IBD patients. 100 patients of these had Crohn's disease, and 27% of these patients had surgery. And all patients were on medical prophylaxis. So what we use options are limited really by the drug availability, especially during the last 10 years due to political unrest and the civil war. So one day you have everything, one day you have nothing. So we commonly use thiopurines. They are the mainstay of management, and we keep anti-TNF alpha for the high-risk patients because we don't have too much of those. And if you just I hope that everyone here is is understanding, but even the types today, you have the originator, for example, Remicade, and tomorrow all of a sudden the supplier will bring you a biosimilar, and the next month you will have the originator again, and you never hear about shifting patient from biosimilar to originator, but it happens in Libya. Unfortunately, some doctors here are still using 5-aminosalicylic acids for Crohn's disease, and I'm sure this will stop very soon. So in conclusion, post-operative recurrence is a very common problem, and it's important to start early prophylaxis and treatment so that we don't reach tissue damage and surgical remission, surgical recurrence. Risk stratification is very important and should guide our treatment to safe resources. All patients should be encouraged to stop smoking. Anti-TNF alpha is the best therapy to date as prophylaxis after surgery, and it's used in the high-risk patients. Early endoscopy, 6 to 12 months after surgery, should be used to guide future treatment. We have to escalate treatment based on endoscopy, and the difficult patients should be discussed in MDT meeting with the surgeons and the radiologist, and to discuss with the patient as well about their preference. Thank you very much for listening.
Thank you very much, Professor Salim, for this very nice and demonstrative lecture. And now,
thank you.
We have a question. Yes.
Is there any question from the floor?
I have a question too.
Yes.
Professor
Thanks,
Abir.
Professor Salim Shtawiya, for this nice presentation and very illustrative in just many slides, helping us and taking the algorithm for the use. But I have two query about if the patient refuse colonoscopy and he's at high risk from the start, and you know that there is now more data about use of luminal or gut ultrasound for assessing the patient can play a role in post-operative recurrence assessment. That is the first question.
Thanks, Professor Izzat. I'm sure you know better regarding endoscopic ultrasound. Unfortunately, we don't have it here, but endoscopic ultrasound plays a role, up to my knowledge, in perennial disease and fistulating disease. Rather than
just abdominal ultrasound for gut.
Sorry. Yeah. Abdominal ultrasound, just conventional transabdominal ultrasound, you mean?
Yes, that is.
Yes. Well, depending on the experience, in experienced hands, transabdominal ultrasound plays a role now in follow-up. And if the patient is not willing to have colonoscopy, then endoscopic ultrasound, transabdominal ultrasound has to be used, or alternatively, MR enterography can be used as well.
The second question about the treatment. You know that all the studies depend on anti-TNF, especially infliximab, in post-operative recurrence. Do you think there is a good data about use of ustekinumab or vedolizumab in treatment post-operative recurrence?
Not up to my knowledge now. Ustekinumab, and Vedo, they don't have good data in the post-operative setting.
Okay, thank you.
You're welcome. Thank you.
Professor Abir.
Dr. Salim, thank you for this updated lecture. Very important topic. I'm asking about the role. Anyone studied the role of methotrexate post-operative as ileocecal involvement? We have another option, which is methotrexate, especially if we have extraintestinal manifestation. Ileocecal Crohn's disease can respond لميثوتراكسيت. What about post-operative?
The short answer is I don't know. I didn't come across good studies in this regard.
Okay, I had a question, Professor. I actually had a case and I want to consult you about this case. The patient was about 37 years old and he presented with appendicular mass, and by investigation it showed to be ileal Crohn's with abscess formation. He was drained with ultrasound and he was given strong antibiotics, and he was assessed and started treatment after ileocolonoscopy, which showed that the patient has ileal Crohn's. At this stage, would you suggest surgery for the patient? I hope this question is not out of the scope of the lecture, but I mean a real-time case.
Nice. So this patient is 37 years old, and
Yes.
This is the first presentation, isn't it?
Yes, this was his first presentation.
Yeah, I mean, if the patient has ileal disease and she doesn't have fibrotic stricture and it's inflammatory, I would go for biological treatment, mainly anti-TNF alpha, rather than considering surgery, unless MRI shows that there is pre-stenotic dilatation or she has obstructive symptoms.
Yes, but many of the paper I read, they said that if the patient has exclusive ileal disease, you may go for surgery.
Yes, of course. It depends on who's talking. If it's a surgeon, they would advise to go to surgery, especially if you have, they call it limited ileal disease. But again, we know that surgery isn't the cure for Crohn's disease. So it depends on your
Yes.
colonoscopy, actually. If colonoscopy shows that the stricture is inflammatory and if the patient is willing, we have to consider the patient wishes as well. If the patient is willing to go to surgery, then that could be considered, but it has to be clear to her that surgery isn't the end of the road. She will be having medications after. If she decides against surgery, especially if she's a young active lady who cares about her figure, then we can go for anti-TNF alpha.
I think I have a comment, Professor Ameni, for this patient.
Yes,
You
I was ambitious. I was going to ask you really, Professor, for your opinion.
You have to do more and more effort to confirm that is an isolated ileal disease. It may be a small bowel disease, may be anal or rectal segment or patch of Crohn's, and now you shift from isolated ileal to, as we said yesterday, ileocolonic, ileoanal, and something like this. Second, if the patient is clear from pus and no obstruction, no stenosis, no small bowel dilation, you have to start even pre-operative. If the decision is to do operation, you have to start the pre-operative biologics, especially anti-TNF, and maintain post-operative biologics, especially anti-TNF. If you use that, it means these patients, the power of healing is bad and maybe suffering from fistula even post-surgery. So you have to assess the conditions pre-operative and post-operative secure with the use of these biologics, and you have previously full confirmation that there is no small bowel or no rectal or no anal or no patchy of Crohn's disease along the colon.
Yes, if I want to extend my question, Professor Izzat, to my opinion, only this patient was exclusively ileal. But even if you go with the endoscope and you see a normal colon, by biopsy, usually he says that there is element of colitis.
No, not the colitis. He should say that he's consistent with Crohn's, and never the conventional term, it is just a colitis. It's not a colitis. There is a data confirming that the patient and the biopsy go towards Crohn's colitis, not towards the conventional colitis we commonly read in the report. And never forget, a lot of patients we have escape surgery when we use biologics in this group. Commonly, we use isolated ileal resection if there is ileal stricture, hindering the response.
Yes. I agree very much with you because besides what you say that stricture is an indication, Crohn's disease is a progressive disease. So what is the guarantee that after you do ileal resection, the disease will not recur in any place else?
Yes,
so
that is
I really
what I said. Yeah, the pre and post operative biology.
Thank you very much.
May I add something, Dr. Amani?
Yes, Professor.
I think Dr. Izzat also meant that you have to confirm that there is no other involvement in the small intestine or an upper GI, not only the colon, because maybe if you have only ileal disease, that's fine. Fibrostenotic might the surgery might help, but if there is extensive small intestinal disease, I think the surgery is not the solution. We will end up with the short gut syndrome.
Dr. Negah, are you ready to any question now?
Yes, I have a question, please, Professor Izzat.
Yeah, go on.
Professor Ishtawi, you are most welcome in our 5th wave of IBD EDU.
شكرا يا باشا.
شكرا. I think you talk about the selective surgery or elective surgery, which means patient with stricture Crohn's or fistulizing Crohn's in remission, or you are inducing remission by surgical procedure. But what about patients that go for emergency surgery? Patients that is Crohn's, neglected for years, not diagnosed, going for severe inflammation, transmural, peritonitis, perforation, and doing colostomy. What is the post-operative care? Antibiotics, anti-TNF, when to give anti-TNF, and the antibiotic use for how long post-operative? We face many cases like this, and I need to know, or I need to discuss together what is the best medication to deal with these cases.
Thank you very much for your complicated and practical question. So what we do here actually is we discuss with our surgical colleagues. We usually, of course, they will follow the patients with supportive treatment and antibiotics. We, once the patient is discharged, we give them metronidazole. We start them straight away on anti-TNF alpha as soon as they are well enough and as soon as we are sure that there is no wound infection or any collection in the abdomen. I don't know what people in Egypt do, and I'm willing to hear.
Just a small comment, Dr. Negah, we have to differentiate between just fistulizing with pericolonic or pericolic or periileal collection or rupture gut. The patient with pericolic collection, commonly you start antibiotics for about 3 months, metronidazole, Cipro, and you can start after clearing of this pus collection and not before the use of antigen. Otherwise, if the patient in a rupture gut and open an emergency and the biopsy said he's a Crohn's disease, now he should start from just 4 weeks post-surgical, the induction and maintenance of the biologics, and commonly we use anti-TNF. And even so, for the patient for follow-up, we're using antibiotics the same duration, at least 1-2 months, with commonly used metronidazole and ciprofloxacin. I think there is a matter of discussion about this.
I agree with you, Professor Izzat. I talk about the patient with rupture gut.
Yes.
And I think we give anti-TNF as soon as possible we can. When he do surgery and given antibiotics for 1 or 2 weeks, his parameters of septicemia and the peritonitis declining, we have to begin anti-TNF as soon as possible. But I wanted to ask you a question. In these cases, do we begin with the standard dose 5 mg per kg, or you prefer to raise the dose up to 10 milligram per kg?
In these patients per se, they do a proactive assessment of TNF level, that is anti-TNF drugs. This is one of the risky group of patients not using the proactive, the reactive assessment of the drug. We commonly give him the anti-TNF in the standard dose and taking a blood sample after every 2 weeks for assessment of the drug level. Because when escalates the dose here, it's a risky patient not to start by 10 milligram. It's better go on 5 milligram per kilogram body weight, but you have to use it with combined with immune modulators as we commonly use. And this highly indicated for proactive anti-TNF drug level assessment and antibody.
Yes, I agree with you. And we go for the standard dose combined with immunomodulators and also antibiotics for 2 to 3 months. Thank you.
Thank you. Shifting for the next session, please.
Thank you, professors. And now we shift to the next session. Professor Amira, Professor Wafa.
Professor Dayan.
السلام عليكم.
Wafa.
السلام عليكم جميعا. It's a great honor to meet my dear professors and colleagues today in IBD EDU 7th wave, and I'd like to thank Professor Dr. Azzat for his kind invitation. Now we will present Professor Dr. Khalid Ali. He will talk about UC in pediatric. What is the difference? Welcome, Dr. Khalid.
Thank you, my dear Professor Wafa. Thank you for all. It's my pleasure to be with you today, present my lecture to you.
Dr. Khalid, I hope Professor Amina here, Professor Amira Shams hear us.
Yes, I hear you now.
Yes, you are for the first time on our platform for IBD.
أيوة يا دكتور خالد أنا معاكم. And it is congratulations, but
بس احنا السكرين باين معانا حضرتك.
نعم
الفيديو مع حضرتك مش لينك معانا.
مش شغال، مش لينك. ايوه
عشان كده.
اسك بس زي
الو دكتور خالد.
Yes, Professor Amir, I will start. Thank you. بسم الله الرحمن الرحيم. Today we will talk about pediatric UC. What's the difference? At first, as we know, ulcerative colitis is a chronic relapsing inflammatory condition of the colon from the rectum proximally. The incidence of pediatric UC, which form roughly about 15 to 20% of all patients with UC, ranging between 1 to 4 per 100,000 per year in most North American and European regions. And we have the childhood onset UC is extensive in about 60 to 80% of all cases, which is twice as in adults. IBD, as we know, combination of genetic, environmental, immunological factors, and the problem of dysbiosis leading to IBD. IBD, by the numbers, we have about 1.6 million Americans have IBD. Of them, about 80,000 patients are children under 18 years old, with about 70,000 new cases each year. This figure shows the geographical distribution about incidence of childhood onset UC per 100,000 per year in different countries. The pediatric IBD Porto group of the European Society of Pediatric Gastroenterology, Hepatology and Nutrition published what's called IBD, pediatric IBD classes criteria into 5 classes. We have pediatric Crohn's disease or CD, colonic CD, and we have ulcerative colitis and atypical ulcerative colitis, and what's called IBD unclassified. Sensitivity and specificity of IBD classes to differentiate UC from CD and IBD unclassified about 80% and 84%, and to differentiate CD from IBD unclassified and UC was about 78 and 94%. Now I will talk about management of pediatric ulcerative colitis according to the ECHO guidelines and also the guidelines of European Society of pediatric gastroenterology, hepatology, and nutrition. At first, how to assess and predict disease activity in pediatric UC. Recommendations: disease activity should be monitored at every visit utilizing what is called pediatric UC activity index at diagnosis, before major therapeutic modifications, and for cancer surveillance, and when it's not clear if symptoms are disease related, especially if we have marker elevated like calprotectin, but it's not routinely indicated during relapses that are not severe. If available, fecal calprotectin should be obtained while in sustained clinical remission, and endoscopic evaluation should be considered when calprotectin is high. Clinical manifestations of UC, as we know: diarrhea, bloody diarrhea or rectal bleeding, urgency, tenesmus, mucus per stool, crampy abdominal pain, weight loss, fever, tachycardia. Severity of these symptoms very important: mild, moderate, or severe, which correlate with extent of disease and will affect my management of my patient. This is the frequency of symptoms, with the most common bloody diarrhea or hematochezia. Children also have some unique related considerations other than in adults, like puberty, gross nutrition, and bone mineral density, and also psychological effect on children and their families. This is the Montreal classification for extent and severity of UC, and we can classify according to the extent. We have ulcerative proctitis, left-sided colitis, or extensive pancolitis, and also according to severity: patient in remission, asymptomatic patient, or mild or moderate or severe UC. This is the figures show with Montreal classification. And as we know, because disease extent has been consistently associated with disease severity, it's not surprising for us that pediatric UC has a worse disease course, with about 30 to 40% colectomy rate at 10 years, as compared with 20% only in adults. About 25 to 30% of the children with UC will require admission for an acute extirpation before transitioning to adult care. The use of Paris classification also advocated for phenotyping pediatric UC, and this is additional labels of very early onset IBD, less than 6 years of age, and also we have what's called infantile IBD and neonatal IBD in first 28 days of life. This is the pediatric UC activity index we can use to assess activity in pediatric UC, depending on different criteria: abdominal pain, bleeding, stool consistency, number of stools per day, nocturnal stool, the activity level of the patient, no limitation of activity, occasional limitation, or severe restricted activity. And we can remission when activity index less than 10. From 10 to 34, we have mild; 35 to 64, moderate; 65 and more, we have severe activity. Clinically significant response is defined as pediatric UC activity index change at least 20 points. Long-term prognosis is better in patients who achieve complete clinical remission during the first 3 months of diagnosis. Also, we have the Mayo scoring system for assessment of activity and for monitoring treatment response. Scores range from 0 to 12. We have less than 2 clinical remission, from 3 to 4 mild activity, from 6 to 10 moderate, from 11 to 12 severe activity. In Mayo score, we depend on bowel movement or bowel frequency, rectal bleeding, and also we have what's called endoscopic subscore for assessment of endoscopic activity. As we know, endoscopy is the reference standard to evaluate mucosal inflammation. And also we have what's called the modified Mayo endoscopic score, which combine also the extent plus the Mayo endoscopic score. This is the Mayo endoscopic score. We have a score 0, normal mucosa; score 1, just erythema, decreased vascular pattern, and mild friability; score 2, we have marked erythema, absent vascular pattern, friability, and erosion; and the score 3, we have spontaneous bleeding and ulceration. Also, we have the ulcerative colitis endoscopic index of severity, which is validated to assess activity of UC in children. Don't forget CRC or colorectal cancer surveillance by trained endoscopist following 8 to 10 years of disease duration, except in case of primary sclerosing cholangitis. And according to the same for children. Chrome endoscopy still can help us in case of screening. This is the endoscopic index of severity. You see endoscopic index of severity. What about fecal markers for assessment of activity? High correlation of calprotectin was present with clinical activity, endoscopic and histological indices in both children and adults. And given the fact that significant endoscopic disease may be present in about 20% of children with pediatric UC activity index less than 10, which means they are in remission according to pediatric UC activity index, but actually we have significant endoscopic disease. So it's reasonable to measure calprotectin in this group to assess the mucosal healing. And I can go to endoscopy if I have fecal calprotectin is high. Till now, we have no ideal cutoff value of fecal calprotectin, but cutoff value more than 250 more accurately can predict mucosal inflammation. Lab test biomarkers should be used to confirm endoscopic setting of primary sclerosing cholangitis. Blood tests like CBC, albumin, transaminases, CRB, and ESR should be performed regularly depending on symptoms, at least every 3 months while on immunosuppressive medication, and at least every 6 to 12 months otherwise. Also, don't forget to test for renal functions in patients taking 5-ASA or mesalamine. In contrast to adult UC, high-sensitive CRB not suitable to differentiate between remission and relapse in children with normal CRB. Albumin, serum albumin level was the only significant lab test that was predicted for severe colitis in 1-year follow-up study. In another study, elevated white blood cell count and low hematocrit value measured at diagnosis associated also with colectomy. As regards the B-ANCA, about 60% of children are B-ANCA positive at diagnosis, and a recent Porto Group multi-center retrospective studies on more than 800 children with chronic IBD, they found that B-ANCA predicted the need for biologics in UC. This is the predictors of aggressive pediatric UC at diagnosis, pancolitis and severe colitis when pediatric UC activity index more than 65. This is the bad prognostic factors that can help us in assessment. What about medical management and how to manage patient child with UC medically? At first, 5-ASA and enemas. According to the recommendations, oral 5-ASA compounds are recommended as first line induction and maintenance for mild to moderate UC. Combined oral and rectal 5-ASA is more effective than oral 5-ASA monotherapy. Rectal monotherapy should be reserved for mild to moderate ulcerative proctitis, which is uncommon in pediatrics. When rectal therapy used, 5-ASA is preferred over steroids. Only sulfasalazine available in liquid formulation also can be effective in case of arthritis, but as we know, we have adverse events of sulfasalazine. Suppositories useful for limited proctitis, while foam and liquid mesalamine enema can be for more extensive colitis. Dosing 5-ASA once daily can be considered for induction of remission and for maintenance. In the MAPIT trial, randomized the children with mild to moderate UC into once versus twice daily with comparable outcomes, no difference between 2 regimens. It's better to give once for better compliance, as we know. The effective induction dose should be continued as the maintenance dose. Maintenance therapy should be continued in pediatric patients. Treatment modification should be considered in patients don't show initial response within 2-3 weeks. Acute mesalamine intolerance could present as acute exacerbation of UC. This is very important. Usually occur within the first months of treatment and symptoms resolve within days of cessation. We have rectal tacrolimus may be considered in patients with ulcerative proctitis are either refractory or intolerant to mesalamine or steroid topical therapies. What about steroid? Recommendations: oral steroids should be used as second-line treatment for mild moderate UC not responding to 5-ASA, and may be considered as first line in the higher end of moderate disease. Severe UC should receive IV steroids, as Professor Allen said before. Second-generation oral steroids can be used in children with lower systemic effect, such as beclomethasone and budesonide multimatrix. Steroids are not recommended, as we know, for maintaining remission. Steroid sparing strategy should be applied for maintenance. Recommended daily dose about 1 milligram per kilogram body weight per day, maximum 40 for 2-3 weeks, and then we start tapering like this schedule. In patient more than 30 kilogram, dosing schedule of bipropionate about 5 milligram once daily for 4 weeks, and for budesonide about 9 milligram for 8 weeks. And we have no evidence to make tapering of these medications. We can stop them suddenly. The term steroid dependency applied to patients who are unable to stop steroids with recurrence of activity, or who have relapse requiring steroids within 3 months of stopping steroids. Children with UC have more steroid-related complications than in adults, including osteopenia, glaucoma, cataracts, and also the problem of adrenal suppression in patients taking high steroid for long duration, more than 3 months. As we know, ECHO statement in adults suggests supplementation with vitamin D while on steroid therapy, but we have no clear evidence to support supplementation of vitamin D in those who are not deficient. What about immunomodulators? Thiopurines recommended for maintaining remission in children who are steroid dependent or relapsing frequently, more than 2 relapses per year. Also, thiopurines should not be used for induction of remission in pediatric UC. Measuring thiopurine metabolites is recommended in patients with incomplete response and in patients who present with leukopenia or elevated liver enzymes or poor compliance is suspected. Don't forget to make thiopurine methyltransferase activity to reduce the dose in heterozygous and avoid thiopurines in homozygous, with regular monitoring of blood counts and liver functions. Very important. The dose about 2 to 2.5 milligram per kilogram body weight for azathioprine, and 1 to 1.5 milligram per kilogram body weight for 6 mercaptopurine. We should discontinue thiopurines if we have clinically significant myelosuppression or pancreatitis. What about withdrawal of thiopurines? We must weight the risk of relapse against the benefit of withdrawal, and we can consider the withdrawal of thiopurines in patients with sustained clinical remission at least 1 year and better with histological remission. Methotrexate rarely to be considered in UC. What about biologics in pediatric? Infliximab considered in chronic active or steroid-dependent UC and controlled by 5-ASA and thiopurines. Adalimumab and golimumab also can be used, but have no role in patients with primary non-response to infliximab. They can help us in patients who initially respond and then lost response or intolerant to infliximab. Vedolizumab also can be considered in chronically active or steroid-dependent patient as second line of therapy after TNF failure. In children, also like in adults, don't forget screening for TB, virology. Also, in children, we may need high initial dosing of infliximab in children with low body weight. And also, we can give rapid infusion of infliximab over 1 hour with the same safety like slow infusion. We can give infliximab in combination with immunomodulators, as we know, to reduce the production of antibodies, and we can discontinue immunomodulators about after 6 months, especially in boys, after ensuring trough infliximab level. Don't forget measurement drug level and antibody in case of use of biologic treatment. Active disease was treated with infliximab or adalimumab. We must check for drug level and antibody. If we have negative or low antibody titer but low drug level, we can increase the dose or decrease the gap or frequency between dosage. If we have low level and high antibody titer, we can switch to another anti-TNF. If we have adequate level with no response, we can switch to another class. This is the monitoring of treatment in patient taking 5-ASA and or biologics, and how we can go to endoscopic evaluation depending on fecal calprotectin if elevated in case of clinical remission. I will escape this surgical consideration. Elective colectomy should be considered in children with active UC or steroid dependent. Restorative proctocolectomy and covering loop ileostomy is the recommended elective surgery in children. 3-stage procedure also is recommended for patients with acute severe colitis, and we can in children use the minimally laparoscopic approach. Please don't forget to exclude Crohn's disease before time of surgery. About extra and standard manifestation in children, we have the problem of peripheral arthritis, which can be treated by first line with sulfasalazine and also anti-TNF. Primary sclerosing cholangitis and the screening by transaminases, GGT. Don't forget the ultrasound, MRCP, and their role in screening for primary sclerosing cholangitis and also for cholangiocarcinoma in case of pediatric UC combined with sclerosing cholangitis. The issue of nutrition, growth, and bone health is important in children, as I said before. Psychological assessment and psychological support are very important also in pediatric UC, and we can use some measures like pill box regarding the medications to give help to patient to be compliant with our medication and follow up. Very early onset IBD in children less than 2 years. We must exclude allergic colitis, immunological disorders. The underlying genetic defects also should be searched for. This is the algorithm for treatment. This is a summary of what I said before about use of 5-ASA, steroids, cypurines, and biologics. For acute severe colitis, I think we repeat the same as Professor Allen said before for acute severe UC or ASUC with some few differences in children. I will be rapid. Only recommendation. The most important I want to say in children, in case of ASUC, it's very important to exclude infections as Dr. difficile toxins A and B should be done. Cytomegalovirus, very important, and other infections. Avoid non-steroidal anti-inflammatory drugs. Opiates with caution. Should exclude bowel perforation in these cases. Nutritional support is important. Thromboprophylaxis in children is an important issue, and we must make thromboprophylaxis only if we have one or more risk factors in adolescent, but before puberty, it must be used with caution. 5-ASA, no rule in ASUC. Antibiotics also, especially if there is infection only, otherwise we cannot give antibiotics. Steroid methylprednisolone is a cornerstone. It's better than hydrocortisone given IV after hospital admission. Don't forget toxic megacolon should be excluded by X-ray. Even if X-ray is normal, but I have signs of peritonitis, I must proceed to CT and MRI to exclude toxic megacolon, which will need surgery. The second line therapy include also infliximab, anti-TNF, calcineurin inhibitor like cyclosporin and tacrolimus, where the role of cyclosporin and tacrolimus here in ASUC as a rescue therapy only bridge for long-term maintenance. As we said before, infliximab in ASUC can be given in high doses, especially in children, and we can make a small gap between doses to give more response. Finally, this is the last slide, the algorithm for ASUC in children, and we make clinical assessment, admission for IV steroids, antibiotic, as I said, if there is infection, stop 5 ASA to avoid what is called mesalamine intolerance, and then assess in day 3 the pediatric UC activity index, more than 45, 35 to 45, or less than 35. If we have 35 to 45, I can continue to day 5, but if more than 45, I must screening for second line and prepare for second line therapy, anti-TNF and calcineurin inhibitors. At day 5, I make assessment for to start second line if more than 65, and also continue corticosteroid for 2 additional 5 days till I reach finally at day 6 to day 10 and make reassessment again. Thank you very much. Sorry for take more than my time. Thank you.
Thank you, Professor Khaled, for this elegant lecture.
Thank you very much. Any questions from the floor?
أنا دكتورة أميرة يا دكتورة وفاء. It is a very nice lecture. Dr. Khaled, this lecture could be make it in 3 parts. The symptoms and sign, and then manifestations, not the investigation, and then the treatment, because it is very, very well done lecture. Indeed. The question is, do you face youngest than the children, not the infant, at 6 months, 8 months, like that? You are not a pediatrician, but maybe in your experience or the youngest age.
I didn't see, but since few days, my dear Professor Izzat told me about case, I think 6 months or 8 months.
Yes.
You see, yes, infantile.
What is your procedure? You and the pediatrician, what is your procedure for diagnosis? I have a case, 8 months, 7 months, and the father has Mediterranean fever, and the mother has non-specific colitis. This young, the young infant started to some diarrhea and some bleeding per rectum, and they examine the pediatrician, no polyp, no fissure, no nothing external. Do you think of over UC at that age?
In this age that I said,
calprotectin,
yes.
And pediatric endoscopy, colonoscopy.
بس هو يعني at age less than 2 years or early onset or very early onset, you see, we must exclude, as I said before, the genetic factors, immunological factors, immunological disorders.
Allergic, yes, you said, you mentioned.
Yes. لازم نعمل يعني genetic analysis for this patient, and I think we can proceed for diagnosis for colonoscopy.
طب Dr. Izzat, what why he refer this patient to you, the young patient, the children, the child? For what reason? What is the aim?
No, we didn't refer. We're just talking about this 8 months baby with UC, and I think with our colleague at Cairo, they took a study for his microbiota and send genetic outside because it's very early to be registered in Egypt, between 6 to 8 months. I think in a very early case. So we are interested to follow the case and to assess if there is early genetic change. We call it very early IBD, very early onset IBD. It's beyond the pediatric, it's infantile type.
Yes.
Do you think, Dr. Izzat, that patient I can refer the pediatrician doesn't do any good result with this baby?
Yes.
Do you want to see him or his mother and father?
I think at any time we are interested in everyone suffering from IBD, UC or CD at any age, and we have some consultations from outside. We can talk with Mayo, with John Hopkins Center here, there, and discuss with them the needs for early intervention and the need for special investigation. I think they are more and more convinced with different age.
Okay, so we cannot exclude, we excluded allergy and so, but because his father has a genetic Mediterranean fever and his mother had some non-specific colitis. So this baby should be put under good observation and follow up. And what is the follow up? Making regular or every 3 months calprotectin? What is the procedure?
I think the first is to be sure about diagnosis. The second is frequent assessment and getting the symptom control and even mucosal control if we can. But it's considered to be a very difficult case, and frequent and close doctor-patient relationship is an essential here.
Yeah, because above that we have patients at 7, 8, 9.
Yes.
This is not a problem. But this patient in particular, I am doubt about the diagnosis. Maybe, yes. Maybe another look. Congratulations for the lecture and congratulations for the good conference.
شرفتينا النهارده في البلاتفورم بتاع الاي بي جي ايديو دكتوره اميره، واحنا دايما بنطمع ان حضرتك تكوني معانا كده ومنورانا دايما.
والله انتوا اللي مشرفين.
ربنا يخليك.
Yeah, thank you. Do you have
Shift
any
to the last session, please. The chairperson start.
Okay. السلام عليكم. دكتورة دعاء. Are you ready?
دكتورة عبير. Yes.
دكتورة منى. دكتورة منى.
ازيك؟
دكتورة منى.
ازيك؟ سايبانا كده ليه؟
المايك يا دكتورة منى.
قربي من المايك يا دكتورة منى.
لا اعملي المايك
unmute.
تمام كده الصوت واضح؟
ايوه واضح. ازيك يا دكتورة منى؟
اهلا بيكم.
خير.
كل مرة وانتم طيبين يا رب، ودايما كده كونفرنسز حلوة ومفيدة.
يا رب ان شاء الله.
نورتينا يا منى والله.
منورانا ومستنيين الدسكشن في كل اللابوراتوري مع الاي اي ام اكسترا انتستاينال.
ايوه
ان شاء الله ان شاء الله.
النهارده دي اخر محاضره في اخر سيشن ختموها مسك ان شاء الله. دكتوره دعاء هتتكلم على الاكسترا انتستينال مانيفستيشن ويز اي بي دي. اتفضلي يا دكتوره دعاء.
تمام. بسم الله الرحمن الرحيم. اهلا بحضراتكم في الاي بي دي ايديو 7 ويف. النهارده احنا بنتكلم على الاكسترا انتستينال مانيفستيشن مانجمنت. This is an interesting topic وبيقابلنا كتير. الاكسترا intestinal manifestations they are frequently observed in IPD and they contribute a considerable morbidity and mortality. احنا عارفين ان الاي بي دي patients حوالي 50% منهم بيجي لهم extra intestinal manifestation 1 and 2 and 3 and more than 3 extra intestinal manifestation. كل ما duration بتزيد او اول ما بيبتدي الاي بي دي diagnosis. وفي حوالي 25% of these patients they experience the extra intestinal manifestation before be diagnosed as an IPD. I had a case with pulmonary embolism and then she developed Crohn's after 3 years from the pulmonary embolism without a reason for this pulmonary embolism. So it increases with the disease duration and in patients who already have one extraintestinal manifestation, the probability of second and third increases. Extraintestinal manifestations reported in IBD, we have some systems that are more common than others, like musculoskeletal system. It's about 40% of the patients, they can experience arthritis, peripheral arthritis, type 1 or type 2 arthritis, or axial spondylitis or sacroiliitis. Also, the skin and the mucous membrane, it's very common. Up to 15% of the cases, they can come with skin and mucous membrane manifestations, like the erythema nodosum, which is more common in Crohn's, and pyoderma gangrenosum, which is more common in ulcerative colitis, Sweet syndrome. It's some bit rare, and the pyostomatitis rigitans. The ocular manifestation, up to 5% of the cases, can come with episcleritis, scleritis, and conjunctivitis, even uveitis. Others, yes, they are rare, but we can see patients like hepatopancreatic capillary manifestations. As we see, primary sclerosing cholangitis occurs more common with ulcerative colitis patients, and this is having a very bad prognosis. Renal and genitourinary, hematological, bronchopulmonary, cardiac, endocrinal, and neurological manifestations that can occur with our IBD patients. Not all of them, they are related to the bowel activity. Some extraintestinal manifestations, they are directly related to the bowel activity, like type 1 peripheral arthritis, like erythema nodosum and episcleritis. Some of them, they are not related to the bowel activity, like type 2 peripheral arthritis, ankylosing, axial arthritis, and uveitis. There is an unclear relationship with some extraintestinal manifestation to the bowel disease activity, like pyoderma gangrenosum, and some rare conditions like infective endocarditis, pericarditis, primary sclerosing cholangitis, autoimmune hepatitis, non-alcohol fatty liver disease, which is, yes, we see it, it's common. Sometimes it's a complication of the disease or the medication, like metabolic bone disease, osteoporosis, drug-induced skin disease, skin cancers, cataracts, myocarditis, pericarditis, and the coagulopathies like the venous thromboembolism. The pathogenesis, until now, it's unclear. There is a circulating antibodies, there is filtration in the inflammatory tone, in the neutrophil, in the memory T cells. There is a dysbiosis of the gut microbiota, which leads to inflammation and increase in the mucosal permeability or T cell trafficking. There is a microbial antigen or a material translocation. So the pathogenesis is still not clear. The prevalence, even the prevalence of an extraintestinal manifestation in Crohn's, is more than ulcerative colitis. So this is very nice. This figure showing that the red line shows that this is the prevalence in Crohn's disease. As we see here, that Crohn's one patient can experience up to 5 extraintestinal manifestations in the same patient with Crohn's disease. But the maximum extraintestinal manifestation in ulcerative colitis, it's to 3 extraintestinal manifestations. This is according to Crohn's and colitis 2016. So what's about the current treatment of this extraintestinal manifestation? This figure showing different systems, different extraintestinal manifestation. The single circle, this means that this drug, yes, it's available. Double circle, this means that, yes, we can use it, and this is recommended drug. And the triangle, it's a controversy, it's not, there is no studies or no recommendations for it. As we see that the erythema nodosum, or the skin manifestation, and pyoderma gangrenosum, they are well controlled with the steroids and the peripheral arthritis. But the primary sclerosing cholangitis have a different line of treatment, different line of management, and also, of course, the coagulopathy. We have to add low molecular weight heparin and vitamin K antagonist. So let's deal with every system, beginning with treatment of arthropathies with a conventional and future IBD therapy, as it is the most common system we face. IBD associated arthropathies, they are commonly treated with physical therapy and non-steroidal anti-inflammatory drugs or COX-2 inhibitor as an alternative option to relieve the pain, the swelling, and the stiffness. We can add paracetamol also in minimal inflammation. And of course, to control the intestinal inflammation for the extra-intestinal manifestations that are related to the IBD activity. Short-term use of non-steroidal anti-inflammatory drug is safe, but be careful that the patient is in remission. Long-term use is not recommended by the British Society of Gastroenterology in 2019. Glucocorticoids injection or the use of them, yes, they are considered, but take care also in patients with axial disease. They shouldn't be received with a long-term treatment with a systemic steroid as stated by the EULAR in 2017. Disease-modifying anti-rheumatic drugs, the DMARDs, like the sulfasalazine and the methotrexate, they are considered for resistant peripheral arthritis. What about the biological agents and what's the role in the arthropathies? They are the most efficient class of drugs, yes, to control all these rheumatological manifestations, demonstrated in several randomized control studies and case series for more than 20 years. They have been tested since 2000, and the most commonly used drugs, they are the anti-TNF, the infliximab, one of our oldest drug, and the adalimumab. And they give a very good clinical response up to more than 50% of the cases they show improvement. The other drugs in the TNF inhibitor class, like the golimumab and the certolizumab, yes, they are effective. Many studies also on the golimumab showing that they are very, very effective in ankylosing spondylitis, as they decrease new bone formation. There is no syndesmophytes and less systemic inflammation, but they tested it for ankylosing only, not for extra-intestinal manifestation in IBD. The certolizumab, yes, it's a very effective drug, but to use it as a first-line biology, not after second line, because its response to treatment decreased by 50% after infliximab failure. And this was a study in 2017 showing that infliximab was the most drug in the anti-TNF group, showing the overall response to the drug up to 74% of the patients. After it, the adalimumab, and after it, the certolizumab of the patients. And this is the overall anti-TNF response rate, beginning with the skin manifestations and the arthropathies. They give a very good response, and then the uveitis. What about the VIDU? There was different studies. It was evaluated in many studies, but most of these studies, they are case reports. Its results, they vary according to the study. This is one of the studies which evaluated the VIDU in 173 Crohn's disease patients and in 121 UC patients. They were treated with VIDU, and they checked the response at 0 weeks, 6 weeks, and 14 weeks, 22 weeks, 30 weeks, and 54 weeks. About half of these patients, they have extra-intestinal manifestations. 44.7% they improved, but they found that patients that having inflammatory bowel disease with no extra-intestinal manifestation, about 13.8% of these patients, they developed new extra-intestinal manifestations, which puts this type of biology, or the VIDU, under debate. This slide showing different studies from 2000 till 2019, where they use the infliximab, they try for adalimumab with a very good clinical response of the patients. And then, as we see here, they try to get for the certolizumab, as we said, for it, and the vedolizumab vedolizumab in this trial in 2018, a clinical response for these 4 patients, it gives 3 minimum complete response and 2 recurrence. So it put it still under debate. What about the recent biological agents? Recent biological agents like the tofacitinib, it's a pan-JAK inhibitor in doses 5 and 10 milligram twice daily. It has been evaluated, which have been evaluated for its clinical efficacy in patients with ankylosing spondylitis, and gives this results is giving a very promising results. We are waiting for it. They are still in phase 2 trial. Other JAK inhibitors, they are also giving very promising results. The upadacitinib, it was very promising drug, still under trial, is treating Crohn's disease patients, showing a resolution of more than 50% of extraintestinal manifestation compared with the placebo. Secukinumab, this is targeting interleukin-17. It shows a very clinical good response in ankylosing spondylitis patients, but it gives with Crohn's disease a very deleterious effect where it increases the activity in Crohn's disease patients in phase 3 trial against a placebo. Other drugs like interleukin-23 or secukinumab, they didn't show enough efficacy in phase 3 study for spondyloarthropathies and rheumatoid disease patients. Fingolimod and other more selective sphingosine receptors, the modulators, they are being developed for clinical use in IBD, but their results have not been tested yet in rheumatoid diseases. This slide also showing what's recent, what is where we are in the current stand of JAK inhibitors and other small molecules. The TOFA is giving a very, it's approved already in 2018 for UC, and it's approved for rheumatoid arthritis and psoriasis with a very good results. As we said, the OPA is the upadacitinib in the Crohn's disease, still under trial with a very good results for extraintestinal manifestations, and others more than in the psoriasis or psoriatic arthritis, giving a very good results and still waiting for their results and the phases to be completed. Treatment of the dermatological manifestations. As we said, we can face dermatological manifestations up to 15% of the cases, like erythema nodosum. It's more common in Crohn's disease. It's a raised nodules, tender, that can occur on the extensor surface of the lower limbs. Mild cases, topical steroids, it's enough, using of analgesics, compression stockings, and leg elevation. In severe disease, systemic steroids, immune suppressive therapy, and anti-TNF giving a very good results. For pyoderma gangrenosum, it occurs more common with ulcerative colitis. As we said, its relation to the IBD activity is not clear, but it may improve when there is a very good control for IBD activity. For mild cases, usually it responds to local and topical therapy, intralesional steroids, and moist treatment with the hydroactive dressings and topical sodium chromoglycates. For severe cases, we need systemic therapies such as oral sulfadapine, corticosteroids, and immunomodulators. TNF antibody showing a very good therapeutic results. Another dermatological manifestation, it's rare, but it can occur. It's called Sweat syndrome or acute febrile neutrophilic dermatosis, where there is fever, can occur arthritis, and ocular manifestation. Steroids are very effective, and they heal without scarring. Also, there was a case report using metronidazole, which was very effective. Oral abscess lesions like peritonitis, aside lesions, and severe cases, the piostomatitis vigitans. They give good clinical response to the mouth washes and the topical steroids and anti-TNF also. And this slide also, I'm collecting most of the studies that begin in 2001 for skin manifestations experiencing the infliximab and the adalimumab and the vedolizumab, and the last one, which they tried the ustekinumab. As we see, it's give a very good clinical response for 3 patients and 1 partial response in 1 patient. But these studies, the disadvantage is that they are very small studies on a small number of patients. Treatment of ophthalmological manifestations. Ophthalmological manifestations can occur like episcleritis, and the more severe, which is the scleritis, it's more tender. The patient coming with a red eye and a tender eye, and early diagnosis is very, very important, and early therapy it's mandatory. We can use topical steroids for episcleritis or systemic steroids and refer to ophthalmologist because the patient can lose his vision. So it's a serious extraintestinal manifestation. Also the uveitis, any type of uveitis can occur. Anterior, it's more common, intermediate or posterior or panuveitis. It's independent on IBD activity. Topical systemic steroids, some cases they treated with cyclosporin A with a good clinical response, and successful use of also infliximab for an IBD associated uveitis, giving a very good results. And this slide, a collection of all the studies that have been on the ocular manifestations as an extraintestinal manifestation in IBD patients using steroids and Vedo and also anti-TNF. Treatment of hepatological manifestations, steatosis, non-alcoholic steatohepatitis and cirrhosis. Yes, they are common. Others, they are rare. But the most one which giving a very bad prognosis, which is the primary sclerosing cholangitis, and we face it more with patients suffering from ulcerative colitis, of course, or they can come with a primary sclerosing cholangitis before ulcerative colitis to search for ulcerative colitis. Its treatment is different because there is nothing of the biology can cure it. Biological agents. There was a study on the Vedo with the patients with the primary sclerosing cholangitis and IBD. The Vedo showing no benefit. It doesn't decrease. It didn't decrease the morbidity and mortality of the patients. But they found that the dots. These are the number of patients in the study. As we see here, the blue dots, this is alkaline phosphatase, it drops by more than 20%, and more than about 41.2% of the patients, the red dots, they increase, alkaline phosphatase increase, and the black dots, they are the patients who they was stable in this study with the alkaline phosphatase. So its effect is in about 20.6% of the patients only who decreases the alkaline phosphatase with no response on the primary sclerosing cholangitis. These are the studies collected since 2003 till 2019 on the primary sclerosing cholangitis are very also they are case reports. They are very small number of studies using the anti-TNF and the Vedo, as we said, with no data available about their outcome. In conclusion, extraintestinal manifestation, they are challenging conditions and they require the collaboration of dedicated specialists from the gastroenterologist, dermatologist, ophthalmologist, and rheumatologist, and the pathologist according to the type of the symptom to guarantee the best management of these patients. Still, we need international guidelines in order to homogenize and standardize the assessment of extraintestinal manifestations. Thank you for your attendance. Thank you, and waiting for you all in IBD EDU 8th wave. Thank you.
شكرا دكتورة دعاء for your elegant updated presentation as usual.
Thank you دكتور for the nice presentation.
شايفة دكتورة ندى عندها سؤال.
شكرا
اتفضلي يا دكتورة ندى.
على البرزنتيشن الحلوة دي، بس أنا كنت حابة أسأل حضرتك سؤال. لو عندنا patient واحنا عندنا papers كتير على السيمزي أو على الأمبل بالذات إن هو بيعمل كولايتس، عشان كده احنا أصلا دول الاثنين أنتي تي إن إف اللي احنا مش بنستخدمهم في حالات الأي بي دي. لو في patient روماتويد أرثرايتس على أمبل بعدين جالها manifestations بتاعت كولايتس أو أي بي دي، ازاي نفرق لو كانت البيشنت دي فعلا روماتويد وديفلوبد اي بي دي، ولا هي اي بي دي من الاول والروماتويد ده اكسترا انتستينال مانيفستيشن، وهل حضرتك هتوقفي لها الامبل ولا لا؟
Yes, it's a very good question, but we have the lab. What about the lab of these patients? Yani, you have to do all your lab, and you want to confirm that this patient is IPD or not. You have to do all your measures to confirm that this is an IPD patient ولا لا. وبعدين you have to try the anti-TNF, which giving a very good results.
اوكي، هي هتبقى عندها هاي ماركرز كلها الاي اس ار والسي ار بي.
الفكره
هي the endoscopy and the pathology.
هي اي بي دي، لكن المشكله في الدايجنوزس دايما يلاقي كرايتيريا للدايجنوزس بتاعت الروماتويد فيها مالتيبل كرايتيريا بتلخبطنا. فهل هي البيشنت فعلا كانت اي بي دي من الاول وديفلوبد يعني ومعاها اكسترا انتستينال ارثرايتس مش دايجنوز كروماتويد، ولا بيشنت روماتويد وبسبب الامبل ديفلوبد كولايتس؟ والبديل ايه؟
يا دكتور عزت.
أنا كنت عايزة أسأل الدكتورة منى الأول حاجة، بس يا ترى diagnosis of rheumatoid laboratory investigation for rheumatoid arthritis احنا في العادي بنطلب روماتويد فاكتور وانتي سي سي بي.
بالظبط، يعني هو الروماتويد فاكتور طبعا مع أي حاجة اكسترا انتستينال.
الو
دينا بوزيتيفيتي، انما يعني برضه في حالات الروماتويد الانتي سي سي بي لو بوزيتيف هنكونسيدر فعلا ان هو ممكن يكون روماتويد، طبعا مع الاشعه مع الهيستوري يعني مع بقيه الكرايتيريا. انما قصدي انه اكتر واحد عشان الروماتويد هنقول الانتي سي سي بي طبعا هيساعدنا يعني نفرق.
المشكله ان زي ما بتقول ندى اللولار ساعات بيقول ان مش لازم يكون الروماتويد فاكتور. يعني حضرتك شايفه السنسيتيفيتي بتاعه الروماتويد فاكتور والانتي سي سي بي
الروماتويد فاكتور يعني السنسيتيفيتي بتاعته ما هو سبيسيفيك قوي يعني خالص يعني فيري كومنلي اسوشيتد مع اي حاجه بيدينا بوزيتيف روماتويد فاكتور. انما الانتي سي سي بي السبيسيفيسيتي بتاعته احسن كتير، يعني قصدي لو الحاله طالعه انتي سي سي بي عالي كونسيدرابل يعني ممكن تبقى روماتويد، ما هواش بيدينا زي الروماتويد فاكتور يعني البوزيتيفيتي اللي مع اي حاجه تانية يعني.
بعدين نسمع بعد رأي الدكتور عزت. اتفضل يا دكتور عزت.
هو انا عارف ان ندى بتسأل على الكومن شيرنج، عارفه الشيرنج بتاع الاميونولوجي والاوفرلاب ده من اصعب الحالات. يمكن احنا كنا عملنا الميتنج عليه قبل كده، واب تي ناو السيبريشن والسيكتورايزيشن ده بيبقى صعب جدا. لكن انا اي ثينك ان البريفيوس اسسمنت ان هو العيان شور كرونز وعلى انتي تي ان اف بانت عليه شويه مانيفستيشن فور روماتولوجيكال مانيفستيشن. فالكومن يحصل العكس، ان يحصل حاجه اسمها انتي تي ان اف اسوشيتد كولايتس، واحده من الاميون تشيك كولايتس. واي ثينك ان حضرتك هنا بتكونسيدر العيان تيل ان هو ما فيهوش هاي ايفيدنس اوف كرونز ديسيز، ان الانتي تي ان اف هي البريديسبوزنج في الناس دول. يعني لازم نعرف ان الكومن العكس دايما، ان الانتي تي ان اف ممكن تقلب وتديني اي بي دي لايك كولايتس في بعض الحالات، يمكن في 5 ل 10%، ومكتوبه في البامفلت بتاع الدراج نفسه. لكن الشور دايجنوزس طبعا بالنسبه للدكتوره منى قالته في الروماتويد الانتي سي سي بي مهم قوي. بس اللي انا عايز اساله، هل في انتي سي سي بي بوزيتيف وزاوت جوينت مانيفستيشن؟ يعني احنا كنا عارفين ان الان ايه مثلا في 5-10% موجودين في الجنرال بوبيوليشن without manifestation. فهل الانتي سي سي بي في نفس القصه دي؟
هو الانتي سي سي بي early ماركر، يعني ممكن يبقى عيان عنده انتي سي سي بي بوزيتيف وبعدين يقعد كذا سنه وبعدين يديفلوب روماتويد، يعني هو اتس ان early ماركر، فممكن قوي يبقى بوزيتيف قبل ما يبقى جوينت مانيفستيشن. وطبعا لو هو عالي ده بيبريدكت ان الجوينت مانيفستيشن هتبقى ايروسيف وهتبقى سيفير، لكن ستيل
هو كمان ريليتد بالتتر بتاعه، يعني التتر بتاعه او الليفل بتاعه دايركتلي ريليتد للليجن.
بالظبط كده، لكن ممكن يبقى present early قبل اي manifestation ما تبان.
دكتورة منى، أنا حابة أسأل حضرتك على البرايمري سكليروزنج فالانجيتس. كان في يعني كلام جديد على الايتيوباثوجينيسيس بتاعه في المايكرو، يعني ان المايكروبايوم والبايل اسيدز they share the etiopathogenesis new etiopathogenesis of the primary sclerosing cholangitis. وكان في study اتعملت على small number of patients على using the oral vancomycin. فهل يعني حضرتك ممكن تقول لنا مثلا فعلا البايل اسيدز والمايكروبايوم دي ممكن يفيدونا في البرايمري سكليروزنج؟
بصي، هو طبعا يعني احنا لسه يعني كلام كله كده حاجات بنقراها، انما كبراكتس او يعني فاكتس كده
مفيش ايفيدنس بيز قوي.
بالظبط، مفيش ايفيدنس بيز.
مول ستاديز.
بالظبط.
انا كنت عايزه بقى اسال الدكتوره عزت والدكتوره منى. دكتوره عزت، انت بتعمل HLA B27 to your patients؟
في نسبه منهم بعمل لهم HLA B27 عشان الاوفرلاب، هل هو العيان اكسترا انتستينال IBD ولا هو العيان اوريدي في انكلوزنج لايك تشينج.
لكن بتعملها للناس اللي عندهم
الميكس. خلي بال حضرتك ان في الميكس موجود، ان هو يبقى ترو انكلوزنج ومعاه IBD.
يس، في يعني جزء من البيشنتس هم انكلوزنج ومعاهم HLA B27 بوزيتيف، وفي الجزء اللي هم السيكرولايتس بس وبيبقى معاهم HLA B27 نيجاتيف، والاثنين دول they are not related للاكتيفيتي في IBD.
Yes.
يعني الاثنين دول not related للاكتيفيتي. بس الستاديز كانت كويسه جدا على الانتي TNF معاهم. لو هنرجع للسؤال دكتوره ندى، احنا بنقول ان هي اتس تايب 1 و تايب 2، هل لارج جوينتس ولا سمول جوينتس اللي كانوا افكتد مع يعني او روماتويد بيشنت؟ هل هو كان تايب 2، يعني قصدك اكتر من 5 small joints they are affected with your patients؟
هو كانوا small joints، عشان كده هي كانت ميس دايجنوز.
مفيش large joints يعني.
احنا عندنا بيشنت اوريدي ندى
كانت بتاع الحاله دي.
لا ما كانش فيه راديولوجي اعتمدوا عليها في الدايجنوزز. اصل اليولار كرايتيريا مش لازم يبقى فيه يعني راديولوجي في الدايجنوزز. اليولار كرايتيريا ممكن تجمع 5 كلينيكال كرايتيريا تتشخص روماتويد.
5 كلينيكال على حسب الكرايتيريا. يعني بالضبط. كان اللاب تايب كان بوزيتيف معاكي ولا كان
ايه؟ عالي وسي ار بي عالي، بس هو ما كانتش عامله كالبروتاكتين. ابتدت بقى تظهر السيمبتومز بعد ما كانت ماشيه على ام.
ما هو ده من الكلام اللي بيتكلموا عليه على الامبرال وعلاقته بالكولايتس. ما احنا قلنا كده ان هو كان انديوس كولايتس لايك مانيفستيشن وIBD لايك، يعني يقدر يدي كلاسيك كرونز لايك، وهم بيتكلموا على الامبرال في الحته دي. هو الوحيد اللي مش قادرين ياخدوه يحطوه من الانتي جي ان اف في تريتمنت اوف ذا IBD، لان هو اكتر واحد بيبقى معاه اسوشيتد IBD لايك كولايتس.
احنا اوريدي كان عندنا بيشنت كان عنده الاكسترا انتستينال مانيفستيشن ان ذا تايب اوف تايب 2 بريفرال بولي ارثرايتس، وميس دايجنوزد از روماتويد. هو اعتمدوا في الدياجنوزس برضو زي ما نفس العين بتاع ندى على CRP عالي، كان الروماتويد فاكتور نيجاتيف والانتي CCB نيجاتيف والراديولوجيكال مفيش راديولوجيكال ايفيدنس، فبداوا له الازاسيبرين. يمكن قعد البيشنت اكتر من سنه وبدا يتحسن. فالمهم بعد كده حصل له دايريه، حصل له بدا يجي له السيمتوم. لما جم بقى يعملوا ريفيجن للسيمتوم كانت الدايريه دي موجوده من زمان، ما حدش كان بيساله عليها. المهم اتشخص بعد كده ان هو ulcerative colitis ومعاه الاكسترا انتستينال مانيفستيشن. هي المشكله في العيان ده هو ان الاكسترا انتستينال مانيفستيشن sometimes precede IBD symptom او الكولايتس symptom. فهي دي بس اللي كانت الكونفيوجن.
هو كنا لسه عاملين ميتنج مع الإيميونولوجي جروب والروماتولوجي جروب، وبدانا نربط معاهم دايما يحطوا جوه الكويستشنير بتاعهم اسئله عن الجي اي، لان اقل مانيفستيشن اوف ذا جي اي بتبوش انك تعملي كالبرو، وموستلي بيطلع الكالبرو في الناس دول عالي. يعني بدانا نبوش بالذات مع اقل سيمبتومز. هي مشكله ان الروما دايما الجي اي غير دي اهميه عنده، دايما الكارديو والتشيست والجوينت والسكين. يا دوب دلوقتي بدانا بالنيجوشيشن والكلام معاهم ان احنا نقول لهم والله في لازم يتحط جوه الكويستشنير شويه جي اي. بمجرد ما بتلاقي شويه جي اي دول انت بتبني عليهم شويه لاب زي الكال بروتكتن بروفيسور منى قالت، وده فيري يعني ديتكتور ان في اكتيفيتي فور سامثينج في الجي اي سواء سمول انتستين او لارج. معرفش، انا شايف ان احنا النهارده اليوم جميل جدا، الصحبه جيده جدا سواء الاودينت او التشير بيرسون من اساتذتنا الكبار استاذه اميره والزملاء دكتوره اماني ودكتوره عبير دكتوره وفاء دكتوره منى والسب بروفيسورز الاسيستنت بروفيسور دكتور خالد وطبعا دكتوره دعاء، الجروب بتاع الاي جي ودكتور مؤمن دكتوره ندى دكتوره اسماء اللي هم بيسموهم الاكتيف ممبرز اللي يعني ما بيبطلوش صراحه مجهود معانا وتعب معانا. بس I think we are doing right. امبارح كان يوم جميل جدا والنهارده يوم احسن. ألان شرابتي I think كانت يعني واحده من اهم الجيست سبيكر النهارده، وتابعها على طول الدكتور سالم اشتاوي من ليبيا. I think we are now البلاتفورم بتاعنا بيتنقل تدريجيا من الناشونال للبان ناشونال، و I think we are going outside. المره اللي فاتت كان معانا الاردن، المره ديت احنا معانا اودينت من ليبيا ومن السودان، ومعانا اتندي من سبيكرز من امريكا. I think we are passing gradually toward international platform. ثانك يو على مجهود حضراتكم، ثانك يو على الحضور وعلى الدسكشن. وبنشكر في الاخر حاجتين مهمين جدا، ان كل ده بيبقى عايز دعم قوي جدا، وده اللي قامت بيه جينسن immunology جروب، و good computerized and technology work بيقوم بيه باركود باشمهندس عاصم والجروب اللي معاه. شكرا لحضراتكم، ويهوب ان المره الجايه ان شاء الله الويف 8 تبقى فيزيكال، تبقى فيس تو فيس، ونقدر نانفايت الناس السبيكر من بره يكونوا موجودين. Thank you again.
Thank you. Merci.
Thank you, Professor Aizat, for this. Very nice.
Bye bye.
Bye bye.
Bye bye.
Yes, bye bye.